Okay, everyone. So a warm welcome from Frankfurt to all Congress participants. I would like to quickly introduce ourselves before we start. My name is Nina, and this is Catherine.
I am Catherine.
And we and our team will help you today with the technical moderation of this event. We are very excited that we have almost 300 participants from all over the world. This is very exciting, and it's very good to see all of you. Before we get started with the actual official program, we would also like to go over some organizational points with you. Please make sure that your display name is your actual name. In case Zoom selected your name of your cell phone or your computer, make sure that you rename to your actual name, and you can do this with the right click of your mouse. During the lectures, all microphones and cameras will be turned off to make sure that we have a stable internet connection. And then after each lecture, we will have a Q&A session. If you have a question for a lecture, please write your name into the chat, and you can do so either during or right after the lecture. And please make sure you write your full name into the chat public so all participants can see it. Then during the Q&A session, the MOI team will go through the chat and will call the names in chronological order. Then when it's your turn to ask your question, we will turn on your microphone and your camera so you can ask your question. Now, as you know that we are such a large audience today, we just want to already point out now that we might not be able to get through all of the questions that you have. So please bear with us that we can just go through a limited number of questions after each lecture. So we hope that all of you have a wonderful time during our Congress today. If you should have any other questions besides to the lecturers, feel free to send one of the MOI team members a message in the chat. And without further ado, we now introduce to you Dr. Paul Weigel, the head of the Department of Postgraduate Education and the founder of the Master in Oral Implantology program at Goethe University. So Paul, over to you.
Yeah, thanks very much, Nina, for this nice introduction. And yeah, dear MOI family, dear valued guests, we welcome to the 8th MOI Congress. And we are very happy to have you here, and the students, the alumni, and even a large number of dentists who are not yet a part of our MOI family. And we know it's not a matter, of course, for us that you take time off your job this Friday to attend this event. For those of you who are attending to our Congress and our MOI family the first time, I would like to give you a very brief overview of this called MOI program, which means Master of All Implantology program of the Goethe University. So shortly, our program lasts 2 years and aims to enable graduates to deal with and above all innovations and new therapy concepts independently and fully autonomously, meaning without any help of a third person or organization. And how does this MOI program can realize this? Well, it introduced participants to the latest innovations and state-of-the-art therapy during the program in oral implantology, and evaluate these innovations and therapy concepts on scientific articles. However, you know, and you can imagine how difficult it is for a clinician who works very nice on the patients with a lot of skills and experience in surgery and prosto to understand and reading a scientific article with all the statistics and the methodology of scientific work. And now, how can we do this for the students? And I think it's the best way that the students make a master thesis where they have to do a scientific paper by their own. This is the best way to educate them to read a scientific paper later, and not only to read, to evaluate it. If it's a poor paper, it's an excellent paper, can I rely on the content or can I not rely on the content? And of course, this you can only do if you have not a third party in the program paying money and sponsoring, because then you are biased and you cannot talk about free and independently about the science and the issues. And therefore we have no third party in it, and we are very proud on that. And of course, why we have so many clinicians in our program? Yeah, because we customize the program for clinicians who are not able to close their office 2 years. Therefore, we change between a so-called distance learning part, where you do at home the work, the patient treatment, the documentation of your cases, the master thesis, and we have a one-to-one ratio to educate you. And then you have to come twice a year to Frankfurt for 10 days. And here we are more related to hands-on courses, cadaver courses, and of course also lectures. This is in a short way the program, but if you go deeper, we invite you to visit our website. Now back to this online congress. Our online congress, our congress is normally a very important point for us. Every year, normally, we met in Frankfurt to exchange the latest scientific research results and discuss new developments in the field of oral implantology. And it's also in this way, because a meeting, a social event, that we meet us again, the new students and the alumni, and this makes it very special for us. However, you know, this year, the Congress cannot take place in this way because everybody far away from here is grounded due to regulations because of the pandemic. So traveling is more or less not possible, and if then you have to go mostly in quarantine. So most of the organization cancel this kind of congresses. We do not. Why? Because it's very important for us to stay in touch with you, and therefore it's not an option to cancel, and we transfer the format in a so-called online congress, and this is the first time for us, and I'm very proud for my staff that we do it for the first time, and we have no support from a third party or a company to do this. But due to this new technologies with these platforms like Zoom, I think even we can handle these 300 participants on this online congress all over the world. Yeah, we prepare again very fantastic presentations for you, and I'm especially proud that most of our speakers are actually graduates of this MOI program. They will present their master thesis, I talked before, of the current research. And of course, having taught them all in the classroom, I feel very honored that they will return to this stage to present lectures to the next generation. Yeah, so we come first to the speaker number one. Can I have the next slide, please? Yes, it's Dr. David Dowling, and he's coming from Australia. And he's graduated from the University College Cork in 2006. And he starts taking implants and placing implants exactly 12 years ago. And he completed the Master of Oral Implantology of the Goethe University last year in September. And this he is working very nicely on his patients, and now with this graduation. And he presents his thesis, and you can read the title by your own. It's an in vitro comparison of the accuracy of implant surgical guides produced by desktop printers versus commercial produced guides. So, dear David, I hope everything works on the technical side. We look very forward for your presentation, and I'm sure you have prepared everything perfectly. Just in case we will run into the overtime, I will give you a sign. So please try to keep the 20 minutes we give you. Otherwise, yeah, this online congress will never end. Yeah, and the same is, of course, with the other lectures too. Okay, we look forward. Yeah, David, please try to start.
Okay. Thanks, Paul. Can you see my screen there now?
Yes, we can. Works perfectly.
Thanks. It's nice to be.
Do great, my stuffs here. Thank you.
Good. Good morning, ladies and gents. It's nice to be back talking to my MOI family. It's a pity that we can't all be together to discuss and to share all this information, but that's the way the world is at the moment. You might have to excuse me, I'm just getting over a cold, so my throat hasn't been the best. So hopefully it will hold out for the rest of the day. Okay. I'd like to present my thesis today. It was basically an in vitro comparison of the accuracy of implant surgical guides produced by desktop printers versus commercially produced guides. Just as a bit of a background story, like Paul said, I started placing implants about 12 years ago with moderate numbers. I had a foray into guided surgery with a Nobel clinician I learned in the Brannemark Centre here in Perth, and then with the MIS guided system, and both were terrible. Then as I started placing more implants, I needed a more reproducible system that I could find would give me good results consistently. So at that point, I traveled to the to LA to do my first guided course through Blue Sky Bio, and where some of the kind of, I'm going to call them like pioneers of guided surgery, in-house guided surgery, were giving a good course there. So that was my start. So without further ado, I'll just go to the next slide. So, as an introduction, guided implant surgery, it's been studied so much. It's proven to allow accurate placement of implants in a number of situations. But to date, the traditional workflows for fabricating those guides can be extremely time-consuming and convoluted. It used to involve plaster models, sending them off to the lab, getting diagnostic DICOM data, and a team viewer session to bring that all together. So bringing it all in-house is a much more expedient way of doing these things. There are many potential benefits of guided surgery, functionally, aesthetically, from a morbidity perspective for patients. It also allows us to potentially prefabricate a prosthesis. From a collaborative point of view with the treating surgeon, restorative dentist, technician, it allows the transfer of information in a much better means. As you can see from my little slide here on the right-hand side, the lower jaw is a guided surgery completed in less than 2 hours. The upper surgery is a freehand surgery completed by one of my esteemed colleagues. There's been a massive development in the technology in terms of 3D printing. You know, just recently I read an article dated 2013 where they purported the benefits of 3D printed guides, but said that the cost of the machines was prohibitive. Now, these days, we can get a machine like the frozen machine in the slide for, depending on your currency, you know, $200 to $400. The resins themselves per guide, $5 to $10. So what used to be an extremely expensive treatment modality, which we used to obviously have to pass on to a patient, can now be conceivably achieved for less than $40. And obviously then we can transfer this better patient outcome to more patients if it's readily achievable. So the aim of my thesis was to establish that the accuracy of placement of implants designed with free software and free protocols and produced locally or with your own office can be comparable with those mass produced in larger offices and by the paid softwares. The hypothesis was that there'd be no statistically difference between the two production methods for the following variables. And these variables are the common methods of assessing the accuracy of guided surgery across the board. So we have global coronal deviation. That's basically a measure at the entry point in both the cumulative of the horizontal and vertical. We have vertical deviation, i.e. your depth deviation, obviously important when we're talking about damaging the inferior alveolar nerve or the sinus when you're in the maxilla. horizontal deviation when we're in buccolingual dimensions, and angular deviation. Angular deviation has the added importance, and it's something that a lot of people don't understand, in that for people who place relatively long implants, that factor is magnified as we travel further down the length of the implant. And if you consider that we've got the distance from the head of the implant to the guide tube, and from the guide tube to the entry point of the guide, we actually have quite a long distance there when you add in a large implant. So there's a significant factor. Even a small degree can throw us very, very far off. Materials and methods. In my particular case, what I used were 20 different patients who presented to my private clinic for treatment. All of the patients that I selected that were included in this study were for tooth-borne guides. The reason being is generally we select our guides into 3 different tissues of support: tooth-borne, mucosa-borne, or bone-borne. It's been shown by many studies that tooth-borne is the most predictable, so hence I was able to control that variable. For each implant that we were intending to place externally, it was treatment planned in 3Shape Implant Studio. There was a merged STL created of both the patient scan and the implants in place, and then that was exported to the 2 softwares being tested. The control group being the Blue Sky Bio software, and the test group being the Blue Sky Bio software and the photon printer, and the control group being SMOC treatment planning system, and the printer in that case was a Stratasys. So within those softwares, the implants were then virtually placed and surgical guide. So basically the implant overlaid the STL that we exported from 3Shape, and then the guides were designed and fabricated. The models, the surgery was performed in vitro using the MIS keyless guided surgical kit, as you can see in the top left. And the examples of the guides used, bottom left was the Blue Sky Bio guide, on the right hand side was the MIS kit. So once those surgeries were performed, 40 in total, the 3Shape scan bodies were attached to the implant analogs, which had to be custom fabricated for the study, and they were scanned in a D2000 lab scanner. And then these the STLs created from both were measured in a non-commercially available implant position comparer available from the 3Shape. You actually can't get it commercially, unfortunately. I've had a few inquiries since, but it saved my life in terms of comparing these data. And basically that exported the vertical, horizontal, global coronal deviation, and also the angular deviation. So there's a lot of numbers here, but basically all we have to look at is the highlighted boxes. Our global coronal deviation, less than 0.9 for photon, 0.71 for the SMOC. The horizontal deviation in the region of 0.4 for both. The vertical deviation, as I said, a very important factor, 0.03 for the photon, and minus 0.3, which means it wasn't fully sunk to depth. And then in terms of angular deviation, pretty much exactly the same for both. So we have a few basically just box plots here, but you can see there was a number of outliers in both the global coronal deviation and depth deviation, but not so much in the angular deviation. All of that was put through your standard statistical analysis. Again, lots of numbers here, but basically all we need is the highlighted sentence at the bottom, which said that no statistically significant difference between the test groups existed. So for me, this meant that I could now say, right, well, this workflow is validated, and that we can now say, right, reliably, we can do this in-house. These benefits and cost benefits and better treatment outcomes can be passed on to our patients. And that's the reason why I selected this as a thesis subject. So I'm just going to give a very, very simple case report. I don't want to get too complex or bogged down in it. This is a guided implant placement with immediate temporization. So the patient presented complaining of an unusual feeling from the central incisor, which had debonded and been re-cemented by another practitioner and we can see that area of erythema surrounding the 2-1 central incisor. Radiographic evaluation showed there was a potential fracture in the buccal wall and associated breakdown of the overlying bone. So generally, we're all about the prosthetically driven treatment planning at the moment. And just this very, very short little video shows how we can overlay the various STLs and the implant position. And it also shows the potential fracture and area of overlying bony breakdown. So within that little slide, basically we've got the DICOM data, the STL data overlying it, and our guide, which shows us our prosthetically driven access. The guide design, this is the software that I use, and again, just a very, very simple case where we merge the DICOM data and the STLs and generate from the intraoral scanning. So here we can see our DICOM data, STLs of the lower and upper jaw, the STL guide, and our prosthetic access. Just a small bit left in that video. So the guide preparation, this is just an image of it, the guide produced on, again, a very, very cheap $200-300 printer, prints in about 2.5 hours. This is it once it's cured and within the design software. So a very, very simple workflow that can give us a good result and prevent some of those negative implications of freehand surgery, such as poor 3D positioning of our implant, which can lead to so many problems down the line. So just the treatment flow upon removal of the existing restoration from multiple fracture lines. You can see here perfect fit of the guide. You may look at this and say there's a misfit here, but that's actually from the virtual extraction of the tooth within the software. You can see the intimate fit of the drill with the guide. You may notice also that there's no guide sleeve in this. After a period of using the guided system, I found that the tolerance between the drills and the actual sleeves themselves was another potential source of error. So in refining my printing practices, I brought the tolerance between the components down, and it gave a much more firmer and accurate implant placement. Once inserted with high initial stability, we did a dual zone grafting as per Stephen Chu and Dennis Tarnow. Temporary cylinder was attached and an immediate temporary crown fabricated. This is just a stock image of one of my other cases with a titanium cylinder in place. And you can see the maintenance of the contour from sealing that chamber, as Paul might say, after 3 months of healing. So in essence, the aim of this study was to determine, was there a statistical significant difference? And we can see from the results that there wasn't. So we can easily take this back to our own clinics and apply it on a day-to-day basis. The results of this study were in keeping with the most up-to-date meta-analysis as well that we could find. So we know that our testing or our processes were all validated and correct. There were a few limitations I found, being a private practitioner and not doing this in a university setting is due to the financial constraints. A single kit was used for all of the osteotomies, and the resin that we tend to use for printing models, it's a very homogeneous, dense material. So the dulling effect on the drills may have had an effect during the actual the multiple osteotomies needed, but also in terms of seating the implant, and that may well attribute to be responsible for the outliers in the global coronal deviation, because trying to actually get those implant analogs to seat is very, very challenging. So within the limitations of this study, you can conclude that there's statistically no difference between desktop and commercially produced guides. And I have to give thanks to Ulf Neveling in Digident in Germany for helping me with the production of all the SMOC guides and the design of those guides and the access to the software on his side. What I would like to add to the end of it is the pitfalls of guided surgery, as I do have issues with the marketing of guided surgery, you know, by, say, implant reps and companies, in that it's marketed as a substitute for surgical skill, prosthetic skill, planning. There are so many, the errors within guided surgery are cumulative. So every step along the way has the potential to introduce an error, and you could have a catastrophic cascade of errors if you don't know what you're doing. Briefly, we've got each step. So we've got the radiological examination. We could have, there is a certain accuracy associated with the actual radiographic image itself, up to 0.2 millimeters for a CBCT. The artifact in a heavily restored mouth, there are specific protocols to try and avoid or compensate for the artifact, so that guided surgery can still be performed, and obviously movement and positioning. In terms of planning, as you can see from the image on the right-hand side, the implant is basically squeezed in between two cortical plates. Now, from a clinical perspective and having done many guided surgeries, I know that as soon as my guided drill hits the top of that sloped ridge, it's going to go one way or the other. And again, you need the surgical experience to know how to deal with that, or if things are going wrong, to be able to actually deviate from the guided plan and go with a non-guided plan. Within the actual manufacture of the guide itself, we obviously have tolerances within the printers. As we mentioned, my thesis was using a cheaper printer, and there was a large learning curve in trying to establish the protocols to print accurately in there. And again, if you're not used to that, you may produce a guide which is very, very inaccurate. There's been large reports of guide fracture because the actual materials we use for printing guides are relatively brittle. So reports say between 6 and 7% of fractures. Also, we have to consider the supporting tissue of the guide. As I mentioned, I selected tooth-borne guides because the literature shows they are the most accurate form of guide. Mucosa-borne or bone-borne guides don't show the same degree of accuracy for a variety of reasons. Obviously, mucosa is somewhat compressive, and bone has quite an irregular surface, but also it needs very, very large flap reflection to actually achieve a truly bone-supported guide. Other pitfalls of guided surgery: intraoperatively, seating the guide correctly, which can be challenging, and sometimes you can falsely think that you have it seated. In areas where opening or posteriorly, actually concentrically drilling as opposed to putting eccentric forces on the drill sleeve itself can cause massive deviation. Bony necrosis from irrigation, from lack of irrigation. Adequate opening, which was my very, very first failing with guided surgery when I tried to replace a lower 7 with guided surgery. Just doesn't happen sometimes. Component tolerance, as I mentioned earlier, there's a tolerance between the sleeve and the guide, the sleeve and the actual drill itself. So trying to refine those and find a system that you find is adequately equipped to deal with all of those is very, very important. And also the anatomical considerations, as I mentioned, sloping ridges, and also things like the bone itself. It's not a completely homogeneous material where it drills evenly through. We obviously have our cortical layers and our cortical plates and trabecular areas. And what happens is sometimes these will tend to drive us off our actual path. And lastly, we have operator experience. As I said, it's not a substitute for surgical experience. An article by Cassetta, they noted that it doesn't allow surgeries that can't be done with conventional implantology to be completed. It just simplifies those complex steps. As for the future, naturally, digital planning, surgical guides, that leads us nicely into, you know, the realm of pre-made prosthetics, trying to have everything ready to go, because as many of the other surgeons will know, that the surgical aspect can sometimes be very, very easy, but the restorative part not so much. So on the top right, we've got an example of a system newish here in Australia, Audentes, where there's the preoperative planning, surgical planning, and pre-milled titanium bar is delivered on this day of surgery, essentially bringing the surgery day down to just one single sitting. And on the lower right hand side, we've got the Chrome guide, which is a bit more popular in the States, which basically has everything in one go, where from planning to fixation guide to bone reduction guide to a seated temp on those. And that's it for my basic, very, very basic presentation on guided surgery. I hope it's given some information. After 300 or 400 cases of doing that, I feel that I've learned a lot about it. And experience goes a long way in those surgeries, much like conventional surgery. So if the guys want to fire any questions my way, I'm happy to do so.
Yeah, dear David, thank you very much for this lecture, and don't underestimate, this was well done. Everybody can follow easily, and I was also very happy that this kind of lecture is also representing the MOI spirit, that we not only talk about the new things, but we also talk about the pitfalls, about the challenges and so on, that we get really a whole picture of this guided surgery and do it very, very well. And now Catherine will moderate the questions for you. Please, Catherine, which kind of names you have in the chat list?
Thank you, Paul. So our first question comes from our alumni, Alex Zarepnitsky. By the way, he is representing the MOI with a really good sweatshirt. Alex, you got the microphone. Very good.
Good morning, everyone. It's 4 a.m. here in Canada, but I'm glad I woke up early for your presentation, David. It was really, really good and very useful, I think, for our everyday practice. My question is very simple, perhaps, is once you gain some experience, how long does it take you to produce a guide in-house?
Yeah, good. Are you talking about in terms of just purely planning or the actual production?
I guess both. Yeah, if you could just divide it into how long it takes you to plan and how long it takes you to produce one.
So there was actually in some of the research I was doing for this, there was a recent article that's quoting up to about 28 minutes for the actual surgical planning. So purely just the planning aspect, which they quoted was 10 minutes greater than the average conventional analog type one. Personally, I've made a video for some of my MOI colleagues that are in my year, and about 15 minutes from start to finish for a simple or a single tooth would be adequate for the actual surgical part or the actual planning part. And then after that, yes, there is a bit more workflow involved. And basically you're taking it to your printer and getting your printer set up and stuff like that. So getting a good workflow established is very, very important as well. You know, but about 15 minutes it would take me from start to finish when you talk about importing your DICOM, overlaying your STL, planning your position, designing your guide, and then to export it. Okay. And if you've got a nice fast computer, maybe you could chew a few minutes off that. Does that answer your question?
Yeah.
Cool.
Okay, the next one. Catherine?
Yes, next question, Hossa. You are giving your hand. If you could please activate your microphone, then the next question is yours. Unfortunately, your microphone is still deactivated. I gave it to you, but you have to click taking the microphone.
Go to the left corner.
Yes, now it's good.
Corner. Yeah, now we hear you, Hossa. No, we don't hear you.
No, the microphone's not working, actually. Sorry about that. If you want to, you can put your questions in the chat and I can read it out loud for you. Okay?
But first we make a next question until he write his question to the chat. Is there any more?
Next question is from you, Paul, actually.
Ah, okay. Yeah, David, I have two questions. First of all, what do you think about, you have already mentioned the cooling aspect, yeah? Now we have more better working templates, which are like a skeleton, and you can cool better, and so you can flap rising and so on. But we have two different opinions in our kind of family. First of all, I now change more and more the last years to the punching technique, if it's possible. So we only punch the soft tissue in the diameter a little bit less than the final abutment diameter to have a very nice primary healing and attachment. And the others say, no, I still go on with my flaps. So what is your opinion? Because you have a lot of experience and a lot of learning curve, and you tell it us with your pitfalls too, about these two aspects, flap versus punching technique.
Personally, I've seen not in my own hands, but I've seen too many errors from other clinicians in a flapless scenario. But again, that comes back to my initial complaint about the marketing of guided systems. So it's those clinicians who are inexperienced then performing a flapless surgery, okay? Whereas in the hands of someone who's experienced, like the guys in your department and yourself, I think, look, yes, performing a flapless surgery is a reasonable treatment option. I have done quite a few immediate extraction guided then surgeries, and I don't have any issue doing that. What are the ways that we could potentially compensate for that? You did mention the skeleton type guide, where essentially the guide tube is elevated from the surgical guide with space around. There's also within the design software, if you can imagine perpendicular to your guide tube, you can actually place technically another custom implant at the same dimension as your external irrigator on your implant handpiece, and you can actually physically connect that into it so it irrigates directly into the osteotomy. And personally, I do a different drilling protocol myself anyway. I usually perforate cortically, but then I actually run a very, very slow and without irrigation in most instances, so to try and prevent overheating. And it also makes it a lot easier that there's not the irrigation there. It's contentious, but in terms of have I seen overheating or failures from that, not that I could ever really attribute, you know. So I think there's a number of ways around that. Also, another proprietary system, the R2 gate, I believe, which is a double pinned system, may well circumvent the issues with the irrigation.
Yes,
which allows a lot more
easy
access.
The drill is guided, or the whole handpiece is guided with these two pins, right?
Yeah, exactly.
Okay, good. Thank you very much for this nice answer. Catherine, do we have now the written question to David?
Yes, I got the question, but Hossa, I think actually you try again because I could hear you before.
You can hear me now?
Yeah, yes. We can hear you now.
Okay. Oh, thanks God. Okay. Hello everyone. Lovely to see you all. Thank you, David, for a very interesting lecture. So my question, while you are using the guide and you're doing the implant, if you doing the implant at the site and you found there is a problem in the bone, how you change the site of the implant and you have the guide during doing the surgery? This would be a big dilemma. That's why I feel the guide is more pushing from the companies. This is my feeling.
Look, I think proper assessment, preoperative assessment of your site is going to help you to, and again, with experience, understanding the difficulties that you may face. So say, for example, like Paul mentioned, and the case I showed, an immediate extraction case, you have to anticipate that as soon as you start to drill, your guided drill is going to be deflected by the palatal bone, deflected buccally, and they're the kind of situations that can cause an absolute disaster with buccal perforation and buccal placement of your implant. So trying to anticipate those in your planning and not just relying solely on the guide, but on your own surgical experience and being aware of that during the surgery. Or, and that's one of the good things about having control about it yourself, is you could maybe even compensate slightly by changing your osteotomy direction ever so slightly to try and accommodate for something like that. Say, for example, conventionally doing a freehand immediate placement in the anterior zone, we make a mark on the palatal wall that we want to engage, and then tend to change our angle as we perform our osteotomy, so that we don't slip down that palatal wall. And you can even create a separate guide to actually create that initial osteotomy hole. Okay. And that's the good thing about having control of the system yourself, that you can, as a clinician, are able to give your expertise. Whereas with the externally sourced one, often it's someone with absolutely no clinical knowledge just telling you where an implant needs to go. You know? Good, we've lost you again, but hopefully that was
okay. So now time is running. David, once again, I clap my hand. Really good job, and I'm proud that you'll be one of this hopefully alumni with as an ambassador of our program in Australia and all over the world if you invited on the stage. Now we come to the next speaker. This is Gorac Danilovski, and he's coming from Slovenia. And here in Ljubljana, the main city of Slovenia, he graduated in 7 years ago. And he is also finishing the same time like David in September 2019, so last year. And he's working since 2015 with implants and is also with digital dentistry familiar, with guided, and of course with PRF. And this is also this he's eager to do something on research, learning it by a master thesis, and therefore he presents us the results and also the method of his master thesis. His question or his hypothesis is comparison of solid PRF, medium RCF, in combination with bone substitute material versus bone substitute material as graft material for internal sinus lift. And he presents you a pilot study. Dear Gorac, it's your turn now. We'll try to share your screen that you can start with your lecture. Yes. Okay, it works.
Okay, do you hear me?
Yeah, can you speak a little bit louder? Or...
Okay, yeah. So, hello everyone, I'm Gorac Danilovski, and as Professor Weigel mentioned, I'm MY 217, and I'm also ICOI diplomat. I come from
it's frozen.
Ljubljana, Slovenia, so a beautiful city. You should come visit. The comparison. Do you see it?
Okay, guys, I think Gorac is having some problems with your bandwidth. Sorry, Gorac, we have a problem hearing you. Can anybody turn your videos off? I will also turn everybody's videos off, okay? Except for Gorac, of course. But I think it will help with the internet connection. Okay, Gorac, you please go on.
Okay. Yeah, the topic is the comparison of PRF with combination with bone substitute material versus bone substitute material known as grafting material for internal sinus lift procedures, where RCF is relative centrifugation forces, which was introduced by my mentor, that's Professor Ganati, in one of his recent studies. That's just a way how to prepare the PRF. So we all know what PRF is. It's autogenous fibrin matrix. It contains a lot of platelets and leukocytes and growth factors, cytokines, which are pretty much very important with tissue regeneration. And after teeth extraction in the upper posterior region, we often get a lot of bone recession and the sinuses expand, and there is often the need for augmentation in terms of sinus lifting to gain some proper volume of bone to put the implants. So sinus lifts are pretty common. And the PRF is an interesting thing which can be added to these grafting materials to help with the bone regeneration. I assessed the bone regeneration with ISQ, so I measured the implant stability of all the implants I placed in this lifted sinuses with the ISQ from Ostel. So this is what I used, the Ostel ISQ, and this is the PRF Duo centrifuge from Shukrun, which is used to produce the PRF matrices. So the aim of the study was to evaluate the role of PRF at increasing the implant stability after internal lift procedures with immediate implantation, where the PRF was added to the grafting material. And the hypothesis is that adding the PRF to the grafting material for the internal lift with immediate implantation improved the implant stability during the early healing period. Early healing period here means 4 to 8 months after the implant placement. So this is my material and methods. I had 13 patients and I performed a total of 18 procedures that were all included in this study. I used Ostem implants, so all the implants placed were from Ostem and they were from different diameters because of course we have different ridges, different anatomies, so I couldn't stick to one single dimension for every case. So all the implants were 3.5, 4.0, 4.5, and 5.0. I did the sinus, the internal sinus lift. I did it with the help of the cat.
Hello?
Okay.
Hi. Do you see me?
Yeah, now we see it again. We lost your presentation for a second, but now it's back. Don't worry about it.
Oh, okay. So I can continue. All right. Sorry. Well, yeah. So I use this kit, which includes the hydraulic lifter, to safely detach the membrane from the sinus floor. And the subsinus cavity was then filled with grafting material. In terms of grafting material, I divided the patients into 2 groups. So I had the test group and the control group. In the test group, I used to mix the PRF with bone substitute material. And in the control group, I only used bone substitute material as a grafting material. So then I measured the ISQ of all the implants placed immediately after placement, and then after another ISQ measurement after 4 to 8 months. And I compared these results and I used them for statistical analysis. This is the study design. So all the patients needed internal lift and implantation, 2 groups with different grafting materials, immediate implant placement with ISQ, and then another ISQ measurement after 4 to 8 months and data analysis. So now I'm going to show you some case reports, clinical stuff. This is a patient I chose because it's quite interesting because I did 1.6 and 2.6, so I did it on the 2 sides, and the same patient was included in both groups. So I did 1.6 with PRF and 2.6 without PRF. I did a pre-op CBCT where I did some analysis of the bone, and as we can see, this is the region 1.6. The bone width was 7.5 millimeters and the bone height was 6.5. And on the other side, this is the 2.6. We had similar bone, so a little bit less of height, maybe it was 6 millimeters and width was also 6, but it's quite similar to the other side. This is how I prepared the PRF. first do the phlebotomy, drain blood from the patient, then put it in the centrifuge, and then we separate the yellow from the red stuff and put it in the PRF box, put the cover on, let it be for 10 minutes, and then you get nice matrices which can be then used for clinical application. This is the incision full thickness flap at region 1.6. This is actually I placed 2 implants here, 1.5 and 1.6, but 1.5 is irrelevant. So we're just going to move to 1.6. This is the hydraulic lifter that was used to detach the membrane. So it just ejects saline into the sinus, and it helps with membrane detachment. I also did the Valsalva maneuver just to make sure that there was no membrane perforation present. And this is the preparation of the graft material for site 1.6. So I mixed the PRF mattress with the synthetic bone graft, which is 75% hydroxyapatite and 25% beta TCP. I tried to mix it in 1-to-1 ratio. Then I inserted the grafting material into the sinus with the special carrier and condenser. And I placed a 4.0 by 10 implant. As we saw before, the native bone height here was 6.5. So there was some slight elevation of 3.5 millimeters. Everything was sutured up, and I did the measurement of the ISQ. At this stage, we had 74, which is quite well. Then we moved to the other side. This is the same patient, region 2.6, also full thickness flap. The same protocol failure with the membrane, with the hydraulic lifter, and here, as you can see, the grafting material is just the synthetic bone graft, the same one that was used on the other side, just without the PRF. Implant placement 4.0 by 8.5, and all sutured up. And ISQ reading at this site was 79 at the time of implant insertion. This is a post-operative CBCT. We can see 1.6 with the elevated membrane and the bone grafting. And well, we cannot see the PRF on the X-ray, but it's there. And the 2.6 is just the bone particles inside the sinus. This is the prosthetic protocol. The patient showed up, came back after 4 months. So I switched the healing abutments to wider diameter ones to get a better emergence profile. That's what I usually do. And this is after 3 weeks. He showed up, so we have a better emergence profile for the molars especially. I did another ISQ measurement at this point for both implants. So we see 1.6. Here we have 84, which is quite an increase from 74. And on the 2.6, I got a 77, which is quite similar to the one I got at insertion, and that was 79. This is the impression with the trios, and I did a full zirconia crowns glued to tie bases. If I did it today, I would make them all singles, but then I splinted. This is what it looks in mouth at crown delivery. And here we got a X-ray that I did at crown delivery. So that's actually almost 6 months after implant placement. And we can see new bone formation around the implants 1.6 and 2.6, which are visible on the X-ray. And then I did another X-ray just last month. Control panoramic is this one. This is actually 2 years after implant placement, so we can see that the bone already matured, and there is new bone formation around implants 1.6 and 2.6, and everything looks stable, so I'm happy for now. And we'll just keep controlling this patient, see the long-term results. Now, this is just one of the cases that I showed. Now I did this with 13 patients, and then I compared the results, and the results showed that there is some tendency that adding the PRF matrices to the bone graft material have a positive influence on the implant stability, ISQ reading. So the variables were normally distributed and therefore analyzed by the quantitative students t-test, and so statistical significance for all tests was set at p-value less than 0.05. So the data showed that our results were correct in 95% of the cases. This is easier to imagine here. On the left side, we see the ISQ stability reading. The black is at insertion and the gray is at the second stage after 4 to 8 months. So we see that in the test group, we had a bigger improvement of the ISQ than in the control group, which is even more visible on the right graph, where we can see the ISQ improvement in percentage. So for the test group, it was almost 19 to 20, and in the control group, it was about 15. No, the discussion part. So the purpose was to evaluate the potential of the pressed PRF matrices in combination with beta TCP synthetic bone graft material to enhance bone regeneration in internal sinus lift elevation with immediate implant placement. Now, as we know, the PRF is slowly releasing high concentration of cytokines and growth factors. So these migrating cells, which are important in bone generation, are in near proximity of PRF matrix and in constant environment with fibrin and growth factors during their entire maturation cycle. So yeah, this was assessed then by the ISQ readings at insertion and 4 to 8 months later. Of course, there were many limitations to this study. It was a small number of patients that I could include. I had, just 13 patients because I had to finish it on time, and I had to get ethical committee approval from my country because this is actually a study that was done on live patients. So that took some time. So I actually had less than 1 year to make all these cases. And I couldn't really schedule a strict time frame for the second stage to all of them because, you know, it's working with people and some of them just didn't come back after 4 to 8 months. Some of them came back after 1.5 years for the second part, and I couldn't include them in the study, so there was dropout rate. Another limitation is that the residual ridge has different anatomy with different patients, and that's why I had to use different diameters of implants. So this might have also influenced the results. And the implant stability at insertion also heavily depends on surgical techniques. So we can do like under preparation, or we can do bone condensation with the densa burrs, and then you get a great primary stability, which will show on the ISQ. So the conclusion is that within the limitation of this study, we can conclude that the addition of the pressed PRF matrices to the bone grafting material results in bigger increase of the ISQ after the initial healing period of 4 to 8 months in the test group. However, no statistically significant difference was determined in the parameters observed in the present studies. I did find out that the PRF matrices, in addition to the bone graft material, offers better handling and manipulation of the grafting material its own. And considering all this information, we can say that the PRF seems to have a positive influence on the new bone formation in the sinus lift, and it improved the handling, it improved the healing, and I think it also reduces the treatment time in the initial healing period. And on the long run, I guess the bone would regenerate anyway with or without the PRF. But on the short notice, I guess it helps with bone regeneration. Well, that's everything from my side. Thank you very much.
Yeah, thank you very much, dear Goratz, especially also for keeping in time for your nice prepared lecture. So we overcome the internet limitation by switching off the videos of the participants, but they can follow then better and clear your presentation. So Catherine, I hand over. If there are any question for Goratz, please hand over to the participant who asked him something to his lecture.
Thank you, Paul. First question comes from our MOI student, Dr. Jawad Anka. Jawad, you got the microphone.
Hi everyone. Thank you for the lecture. My question is, we have in our clinic sometimes that I thought the evaluation of the timing of taking the PRF, we haven't any consideration for the timing, because what's the difference between fresh PRF and old one? How it's working? We haven't any research. This is my question.
Well, I mean, once you prepare the PRF, once you drain the blood and do the centrifugation, so it takes like 10 minutes to get it done. And I've read that it stays fresh and it can be used for at least an hour and a half after that. It shouldn't dry out, so that would be some time frame when to use it. And if you plan to use it like after 6 or 7 hours, I guess it's not longer useful because it's going to be dry.
Jawad, is this an answer for you? You look like you have a question.
Is there any research for that? I don't think that we have research. Shukran, even the machine cannot give us any limit time for the old and fresh PRF. I asked him this question and he didn't answer me quietly. What do you think, Paul?
Is a question on me?
Yes.
Okay. I don't know also any literature on that, but I have another idea for this PRF. Goratz shows very nicely that there is an improvement in ISQ, which is working a little bit faster, and his 2-year result from one of his study participants show in the end we have the same. So what is the indication of PRF? Look, if you have a very old patient, you have a diabetes, or you have other, let me say, biphosphonate history, and all these things are a little bit, decrease healing velocity and healing capability. This means that the PRF, I think, will help to overcome these compromised patients, especially also for implant placement. And I think there is a high potential for PRF. But if you have healthy patients, this kind of improvement or increasement is small, but still visible. And Goratz shows us nicely that it's visible. And therefore, I cannot answer if there is any literature between the new, fresh PRF and what you say, old PRF. I don't know, but what we can do, I can, in the lunch break, I can ask Sharam, because he's still on the OP theater, because he is one of the experts worldwide for PRF, and he developed very well, you know, and perhaps he can help better than me.
Thank you.
Okay for you?
Thank you.
No problem. Okay, Catherine, have you another question?
Yes, we have more questions. The next question comes from our MOI student, Dr. Aditya. Aditya, you have the microphone.
Hello. Yeah,
Hi.
hello. Okay. My next question is for Dr. Goratz. When you use the crystal approach sinus lift, do you use only liquid PRF, or you use also the solid PRF too? The liquid you mix with the bone material, and the solid you put it inside the socket, or only use the liquid PRF? Yeah.
Well, no, I actually use the solid one that I
you
mix.
only use.
Yeah, I used the solid matrix, breast matrix that I mixed with the bone particles, and then that was used as a grafting material.
Oh, okay. And do you use the red tube, the non-coated ETA for the phlebotomy? For phlebotomy?
Yeah. Yes, I used the back then I used the red tubes. Yes, that was what I got with the machine.
Oh, okay. But what if we use the tube that is coated with ETA, the purple tube? Have you ever used it before for phlebotomy for taking the PRF?
To be honest, I have it in stock, but I never used it. No.
Oh, okay. Yeah, that's all my question. Thank you.
Okay.
Okay, thanks.
Okay.
So the next question comes from our MOI graduate, Dr. Abdul Fattah from Jordan, who visits us from space, apparently, today. Dr. Abdul Fattah, you have the microphone.
Okay, can you hear me?
Yes.
Nice.
Yeah.
Very nice to meet you again. I feel like we are like each and every year. It is not a question how much, it is an observation. Dear doctor, your first case, the pre-op X-ray, CBCT, you can observe a little bit some thickness of the membrane. But the post-op, the thickness, the sinus was very clear. This suggests that the PRF can work well in healing the Schneiderian membrane. Do you agree with me or not? Thank you.
Yeah. Well, I also prescribe antibiotics, amoxicillin, with every patient I do the sinus lift. And I also told him to quit smoking, or at least to reduce it a little bit. And I think this also helped at removing the possible sinus infection. But to be sure that the PRF healed the sinus infection, I don't really think we can say that for 100%.
Yes, there is no study for this. If PRF will improve this kind of healing over infected sinus, but nevertheless, if you know that the sinus is infected, you should not do a sinus floor elevation. Yeah, you should first heal the sinus. I think this is clear. Can I have a next question to you? The point is the following. You use your synthetic bone graft material, and it's okay, and you make a very nice comparison. But which kind of feeling you have, because you work with the PRF and with this stiff PRF, if you don't add this bone material? So you make a so-called summer technique without blood, but the blood is already PRF. So you place only PRF in the sinus after you lifted it with this hydraulic approach, or is it not working because this membrane comes back and will squeeze and press your PRF? What is your meaning on that point? Because if the patient can save the money for the graft material, perhaps he is happy.
Well, I mean, yeah, I'd never done it only with PRF. I always put something in. So also with the hydraulic lifter, this is another disadvantage, or because you never know where the membrane will detach. So it can go one way or another. So if you put a lot of saline inside, it can just go to a completely different direction than you want it to go. And it's quite unpredictable, I would say. And using only PRF, I think it might work, because I mean the point is just to keep the space from the membrane collapse, so some bone regeneration can happen in that space, right?
Okay, because if you had time, or I don't know if you joined it, or you can even read the record in the Moodle platform in our MOI family, we have some webinars, and recently Kenneth Lee showed us PRF and the new kind of approaches, and he shows us that he cook PRF and then it goes very stiff, right? So the resistance against mechanical pressure is nicely, because this is sometimes used also in the plastic surgery for cosmetic surgery in the face. However, this is not the topic of the day, but I think this kind can be a new approach in the future, and perhaps you are eager to invest this to evaluate and to work out this too in the next study, if you do. I hope so. Perhaps we can then only use PRF in another sticky situation. Good. Catherine, do we have another questions for him?
No, at the moment we have no other questions. So I would suggest that we go into our first break. Or Paul, do you have another question?
No, I don't have, and I hope please stay all in and then go make your biology break or eat something or play with your kids or whatever. But stay in this Zoom meeting, because after the break, Tony, a friend of mine, Tony Scullion, our main speaker, which we invite him, is speaking and give his lecture and talk with us all and have a nice question and answer session too. So I hope you come all back or stay in. And I handle over to Catherine if you have something to add for our participants now.
No, Paul basically said it all. You may stay in the meeting. We will just turn the cameras and microphones off for a second, but we'll all stay here in the room. And our keynote speaker, Professor Anton Scullion from the University of Bern, will start his lecture in about 30 minutes, 12:30 German time. All right,
Okay.
thank you guys so much.
See us in 30 minutes again. Thank you.
30 minutes.
Bye-bye.
Bye.
Hallo, Professor Skulian.
Hallo, Frau Jackel. Alles gut?
Ja, alles gut.
Hallo, Professor Weigel. Ich höre dich nicht.
Hallo Toni.
Ah, okay, super.
Ja, die gaben mir jetzt erst den Ton, weißt du? Meine Mitarbeiter bestimmen über mich. Okay.
Also ich habe jetzt versucht, alles so gut es geht.
Ja, wir sehen dich gut.
Ist gut?
Ja, ein bisschen lauter vielleicht.
So ist gut?
So ist gut, ja.
Warte. So?
Mhm.
Ist gut?
Mhm.
Warte nur eine Sekunde.
Ja. Katrin, willst du dann die ersten Worte sagen? Ja?
Alles gut.
Okay.
Habt ihr mehrere Vorträge gehabt heute?
Ja, schon 2.
Mhm.
Und dann nach dir sind nochmal 2.
Ah, okay.
Und du bist genau in der Mitte.
Ich bin in der Mitte. Okay.
Okay. So we have to switch now to English.
Yeah.
Yes, guys, because with our next speaker from Switzerland, we are on very Swiss time. So perfect timing, actually. And we will start the meeting again now. And Dr. Weigel, as always, will introduce our keynote speaker. Paul?
Yeah, thank you, Catherine. And we see a lot of comes back to our online congress of the MOI, Innovation Jumps in Oral Implantology 2020. So Professor Dr. Anton Skulian will talk about etiology, prevention and treatment of mucosal recession at dental implants. And also we include some cases from students and we'll discuss later on, perhaps 20-30 minutes. Yeah, hopefully very interactive. First of all, I have to tell you a little bit about Anton Skulian and about his CV. However, I can tell you if I talk about everything, it will be a lecture for its own. So we don't have time for the lecture for him because he has a very long role, what he is doing and awards and so on. Currently, he is professor and chairman of the Department of Peri-Implant in Bern in Switzerland. And he is also the CEO of the School of Dental Medicine in Bern. And he has made more than 400 articles in peer-reviewed journals. Once again, 400, yeah, and 30 chapters in textbooks, and had delivered. He has made more than 500 lectures. He is also the editor of the book Periodontal Regenerative Therapy and guest editor of the Periodontal 2000 issue entitled Wound Healing in Periodontology and Implantology. And I think this is also his focus in his research today. He is also serving on the board of 12, you hear right, 12 dental journals. So I think if you now place any kind of science or scientific paper, it's a very high probability that he gets it also on his desk. Yeah, and to sum all up, his so-called age index is about 78 in Google Scholar. I think nobody has more, and the Web of Science is 57. But what we call internally in the science community in dentistry, this is a Nobel Prize for the science community in dentistry. It's a distinguished scientific award of the International Association of Dental Research, the ERDR. He is handed over last year, and I think he can very proud of this. And we are very proud that he's lecturing for us. And yeah, he is also a Distinguished Teacher Award of the European Orthodontic Society and some other rewards and prizes. Other jobs, of course, he is leading and also organizing some associations. So he was a past president of Periodontal Research Group of the RDR. He was past president of Swiss Society of Periodontology and European Federation of Periodontology. And currently, he is a president of the International Academy of Periodontology. So I think you now have a small picture about his work, and he is a scientist and he's a clinician. If you see his cases and his hands, you will be very astonished. And because he's so good in hands too, and in research and also in the surgical, let me say, teaching, his cases are not only for the first second, he can show you also 5, 10, 15, 20-year results, which are still looking amazing. So, Tony, this was my introduction for your lecture. I think we have to share now your screen for the first slide, and then we are really welcome you for your lecture and later on with the discussion with the students and me about the issues you mentioned in your lecture. So, yes, we have you.
1 second.
Yeah.
No, this is not the end. Go to the first slide. Yeah.
I can also say, please, you can ask him during the lecture by the chat. Only put your name like the other lectures before, and then after he's stopping, we will ask you for your question. So you can do it also between his lecture, and we appreciate your questions, of course. Yeah, and question him hard, and also sometimes provocative, because we want to have a very nice discussion. Yeah, because we have so many things which are controversially discussed and also published. And now I think, Tony, you are ready to start. Yes?
Thank you very much,
okay.
Paul, for first of all, for inviting me to your Congress and giving me this opportunity to talk for your students and in front of you. And maybe the most important aspect that we need to mention is that we are friends. And I feel privileged to have friends like you. And this is, I think, more important than the papers. So let's start, dear colleagues. I would like to give you an overview about how we diagnose which problems we face when we are dealing with soft tissue recessions at implants, but also to make some comparisons between teeth and implants, and then to elaborate on the different treatment modalities. Of course, this topic is very broad and we could talk for hours. However, I would like to show you now some cases, and you see what we would like to aim in our clinic is to have a stability of the hard tissues and of the soft tissues following placement of an implant. You can see here one example at baseline and then after 10 years regarding hard and soft tissues. So what our aim is to ensure long-term functional and aesthetic success. And we know that we have the situation of the bone. We need to ensure the osseointegration. We know a lot about this, but we also focus more and more in the last years on the so-called soft tissue integration, which seemingly appears a quite important aspect for the long-term outcomes. The stability of the hard and soft tissues are, of course, very, very important. And on long-term basis, we can discuss the issue of probing later. We would like to have a situation that is inflammation-free. And look at some examples, cases that were treated and documented over the years. At 1 year, we always try to look at the same parameters at 10 years, then at 12 years, 50 years, 20 years. And what I want to have in my patient is to have this stability. And this is very important. So when we place the implant, we want to have a stable clinical situation. We talk nowadays also about the so-called biological width, the supracrustal soft tissue, and this will also change during the so-called remodeling phase. And we would like to avoid recessions of the soft tissue over time. You all know the so-called aesthetic parameters, the white and aesthetic score. And I think it's very important to think at these parameters when we plan our cases. So this is a routine case from our clinic. And you see that if the implants are surrounded by keratinized attached soft tissue, we may ensure soft tissue stability, inflammation, free areas that are very important. And here another case restored with osseointegrated implants at 1 year and at 7 years, at 10 years. And you can see that it is a stability that we can obtain. So we do not aim only at 6 months or 1 year or 2 years, but I would like to have the stability over many, many years. So what is the problem that we face? What is a soft tissue dehiscence or a recession at the tooth as an implant? First of all, if you look at the anatomy, and you have learned a lot about this in your course, this is a small summary. We face differences in the blood supply because if you look at the implant side, you have a direct contact between the implant and the bone. You don't have periodontal ligament, and you have, in fact, poorer vascularization, and the diminished blood supply. This is a very important point to keep in mind. And if, for example, we would excise a part of the gingiva at a natural tooth, very often this gingiva comes back, at least partly. If you do the same around an implant, this will be lost. And this is also a very important point to keep in mind. So what is the so-called mucosal seal around the implants? Has two components, the connective tissue and the junction epithelium. So this is something very important. And if you look now at the histology, you can see that the epithelial layer is positioned on the implant surface via hemidesmosomes. It is not a very strong link. And the collagen fibers, if you go more apically, are oriented parallel to the smooth implant surface. They are not inserting. So this is very important. And if you look now at the inflammation at a tooth, as you can see it on this histological slide, and the same inflammatory lesion around an implant, you see that the inflammatory lesion goes faster if you have the same amount of plaque around an implant and reaches the bone compared to the tooth, because due to the anatomy, the inflammatory infiltrate is much better encapsulated around the tooth than around an implant. So if you look now at gingival recessions, as you can see it in these particular cases, one lower jaw, one upper jaw, we may have different etiological factors. It can be due to mechanical trauma, like tooth brushing, to periodontitis, to an orthodontic therapy, or maybe an accident, piercing, or different other parameters, or combination of these parameters, even of periodontitis. However, if you look at recessions around implants, you see one case that was referred to us, and I can tell you that I don't like these cases because I will tell you that it is very difficult to treat. So the main key factor for the etiology, you know what it is? It is the dentist, because these implants were placed by somebody. They didn't grow by themselves in the mouth. I never see an implant growing by himself. So what is now the etiology of the recessions around the implant? First of all, treatment planning. Implants are placed far too vestibularly, or there's a lack or insufficient amount of vestibular bone. The implant may be far too wide if there's a discrepancy between implant size and bony envelope, or maybe an inappropriate distance between two implants or implant and tooth. or the thickness of the mucosa. Of course, it can be also coupled with peri-implant mucositis or peri-implantitis, or different combinations thereof. Look at this case. This case was referred to me, and in this particular case, the implant was placed incorrectly. You see far too facially, you have a huge recession. Luckily, the patient covered it with a lip line. But this case, I can tell you, is a mission impossible to treat with a soft tissue graft. We will discuss it later. Or this case, you see here also the implant was placed a little bit too buccally, or also in this particular case. And also the diameter was maybe too wide. This is, for example, a case that we treated many years ago. It was placed far too facially, and we still could correct it. But you see that we don't have a bone loss here. It is not peri-implantitis. It is just a kind of dehiscence. So in this particular case, we performed GBR, we opened up, and you can observe that we have a fenestration. However, we have two neighboring teeth that keeps very nicely the soft tissue. This is very important. So it is a single implant between two teeth. So we have a prognosis. We may use a GBR, we may use a connective tissue graft additionally. And in this way, we were able to correct the situation. Okay. What about lack of vestibular bone? If you don't have at least 2 millimeters of bone, vestibularly or even lingually, then we may have a problem. This bone is also stabilizing the soft tissue. And you can see it here. After a couple of years, please observe the dehiscence that occurred. Despite the fact that we had enough keratinized tissue, due to the fact that the bone was lacking, we have quite clearly a recession. Of course, if you use a GBR that we very often use, a contour augmentation, then we have a very nice possibility to reconstruct the bone, but also to maintain the soft tissues. And you all know these cases and these techniques. Look at the bone that was regenerated. And in this case, of course, the soft tissue will remain. You see the stability of the bone. And here, we do not face a facial recession. What about the discrepancy between implant size and bony envelope? This is also a frequent problem. However, in this particular case, you can observe that we have the problem monofacially. We can see the implant, the titanium shining through the tissue. Probably the bone is not any longer there facially. However, we still have it mesially and distally. But it was a kind of mistake. Not a big mistake, it happens, but it is something that occurs. Or look at this case. Here again, the size of the implant was far too large, and over the time, dehiscence occurred, a kind of fenestration. What about the inappropriate distance between implants or implants and teeth? We know these rules that were described by Danny Boozer. If we don't have enough distance between a tooth and the implant, we lose the papilla. And if we don't have also the vertical height, then we may also end up in a papilla loss. It is even worse if we have two implants that are very close related to each other. Look at this case. These implants were placed, lower frontal area. However, they were too close to each other. What happens? The bone resorbed. It was not a peri-implantitis, and then the papilla was gone. In these cases, we usually remove one of the implant. We perform a GBR, and we use an implant and a cantilever, because otherwise it is impossible to maintain the soft tissues. What about the mucosa thickness? Look at this case. Here the implant was placed. However, the colleagues looked only at the hard tissue, but they didn't augment the soft tissue. So please keep in mind that you need hard tissue and soft tissue. Otherwise, we end up in this kind of problem. As you can see it facially, we have here a thin mobile mucosa, and this kind of fenestration was created over time. And this is a very good niche for the bacteria. So, of course, we can correct it, and I will show you how we correct these cases. But keep in mind, you need bone, you need correct positioning of the implant, and you need soft tissue. And then we all know the thickness of the mucosa that influences also the stability of the bone. And if the mucosa is very, very thin, then we may face also bone loss over time. Look at some cases. Here, for example, if the mucosa is very thin, regularly we use a connective tissue graft that is placed on the flap or maybe on the fixed at the cervical part of the implant. And in this way, I have enough thickness of the flap. So we prevent a mucosal recession and, of course, ensure periodontal or peri-implant health and also recession formation. Look at this case, the lack of attached keratinized tissue. The colleague didn't think at this point to ensure enough width of keratinized tissue. And what do we have? In fact, a problem related to plaque accumulation and, of course, to recession. Which case is better? Of course, it's not so difficult to tell. If you have enough keratinized stable tissue, it is easier to clean. Sometimes we have also a problem that we can only solve together with a prosthodontist. So if, for example, we have a high smile line, and this case I treated together with Professor Belzer, who is an excellent prosthodontist. So in this case, the implant was placed at the area of 1-1, and you can see that the cervical contour of the natural tooth is different to that of the implant. It's a small difference, maybe 1.5 millimeter. Very difficult to correct. Sometimes small defects are more difficult to correct than large defects. So what can we do? In this case, we describe the technique where we, in fact, augment the soft tissue, but I need a very good prosthodontist who is able to fabricate very slender and concave temporaries that will guide the soft tissues. So first of all, we augment. And then this is a very important design of the crown. You see this concavity will guide, in fact, the soft tissue. And this will, at the very end, improve the level of the soft tissue. So sometimes we need to work in teams because as a single person with one discipline, you cannot cope with all the problems. And this is maybe our strength in burn. So let me show you a very recent study where we looked at the long-term outcomes of peri-implant soft tissues in terms of mucosa recession. And we had the question whether we need keratinized and attached tissue to maintain long-term soft tissue stability. And if you look at the literature, it was only limited to 2 papers. I can tell you 2 papers that were a kind of case series. Very little evidence. So we don't have evidence from randomized controlled clinical studies, but if you don't have attached keratinized mucosa around osseointegrated dental implants, these 2 studies that are available demonstrated more plaque accumulation, more inflammation, and more recession, indicating that we need, in fact, stable soft tissues. Peri-implant mucositis, peri-implantitis are also causing recessions. And from a differential diagnostic point of view, we have to make sure whether we are dealing with only soft tissue dehiscence or it is already a peri-implantitis or a mucositis. Look at this case here. The lady had 7 or 10 millimeters of pockets. And in this case, basically, it was very, very bad to treat, very difficult. So what about the prevention? If you want to prevent recessions around osseointegrated implants, first of all, look at the positioning of the implant, ensure sufficient vestibular and oral bone, appropriate implant diameter in relation to the bony envelope, sufficient distance between 2 implants or implants and teeth, make sure that you have sufficient, at least 2-3 millimeters attached mucosa, and infection control. before you place the implant. That means make sure that you have treated, in fact, the perio problem if you have a perio patient. So what is now the treatment goal of recessions? First of all, I would like to help the patient to clean in order to avoid mucositis and peri-implantitis, and of course to improve the aesthetics. And I would like to ensure long-term stability, as you can see it in this case. So if you look now at a study by Rocuzzo and co-workers, he looked at his patients in his practice over 10 years, and he was able to demonstrate that if the implants are not surrounded by sufficient keratinized tissue, you have more plaque accumulation and more problems on a long-term basis. So after he treated these cases with a free gingival graft, he was able to stabilize them. So what do we do? For example, if we are placing implants with GBR, as in this case, I like to use some kind of strip technique. I use a free gingival graft strip or connective tissue graft. I build up, in fact, the soft tissue over the hard tissue and make sure with some collagen membranes that I can guide, in fact, the keratinized cells. And I ensure that my implants are surrounded by stable attached mucosa. And this is, in fact, very, very important. Think at this, dear colleagues, not only GBR, but also the soft tissue that we need to obtain. So how do we move on around teeth? Let me summarize our techniques. So of course, we have many, many techniques to treat recessions around natural teeth. What we usually do is the tunneling approaches, because I don't like nowadays to cut the papilla. And of course, if we look now at the cases at single recessions, usually I like to use the so-called laterally or coronal advanced tunnel. And please look at this case that I treated about 5 years ago. Very deep recession, about 1 millimeter. This is a huge defect. And you see the situation. This is a huge defect. And what I do in this case is to preserve the papilla, make sure that I can prepare a full thickness flap. This is a full thickness tunnel. The tunnel is in fact a further development of the envelope technique. And the envelope technique was in fact developed in Frankfurt by Professor Retzke. And in fact, what we do is to enlarge an envelope and use a mucoperiosteal preparation with specially designed instruments. I am staying on the bone. And look how thin the tissue is. In such cases, the tissue is very, very thin. So that's why I don't want to use a split thickness approach, because I do not want to perforate the flap. And then, of course, it is very important to cut the inserting fibers at the inner part of the flap. Sometimes I also remove the muscles with a very long blade, as you can see it here, until I can move the parts of the tissue, the two ends of the tunnel together like a so-called double papilla flap, but without vertical releasing incisions. We may use some biologic materials like emdogain, or we can use hyaluronic acid, etc. But in conjunction with a soft tissue graft, I fix it. We fix it with a sling suture usually. It is very important to have it fixed. And then I simply move around. It's very important to train this technique. And in the last 12 years since I'm in Bern, I did about 980 cases. And with this technique, these cases are quite successful. But it is very important to look at every single step. So you see, the connective tissue is mandatory in difficult cases. Then at the very end, I just move the edges of the flap together by using micro needles. The needle length is about 12 millimeters. just moving it together and making sure that I can close it as good as possible. You can see it at a high magnification. So this was a 10 millimeter deep recession together with a pocket of 4 millimeters, 40 millimeter attachment loss. And look at the situation after about, this was after about 3 years, is a complete coverage, 100%. So we gained 30 millimeters of tissue. What do we do now in multiple defects? And you see here what we have to discuss afterwards is, in fact, the results that I obtained with this technique. More than 90% coverage, 96. This is a very good result. Almost in every case, 100%. What do we do now in multiple defects? Of course, we can move the flap coronally, according to the technique described by Zucchelli and De Sanctis, with or without grafting. Or we can also use the tunnel approach, again, with and without grafting. And usually I use this approach. Look at this case, a patient that was in fact treated only with composite fillings, and she had pain in the lower jaw. So you can see here exactly the same technique. I don't cut the frenulum in a previous surgery. So what I do is to cut the frenulum from the inner side, and what I call it internal frenulectomy. But what I need is in fact a very long graft. Okay, so I harvest it from the palate. You can see here a very long incision. So I harvest it from the tuberosity. I go to the central incisor because we need living cells. This is very important. Then I take always a new blade and I split, in fact, the connective tissue from the epithelium. This is, in fact, a kind of split approach. And you have to take care, of course, of the palatal artery. That's very important. So I just go in a way that I can see my blade shining through. You see the connective tissue graft, and then a third incision. And with this incision, in fact, I split the graft from the bone. This is a difficult case because you can see that the palate is a kind of flat palate. And in this case, the palatal artery is very close, you know. So this is a challenging case. And of course, this connective tissue was of about 4 centimeters. This is usually the maximum that we can harvest. We can also harvest another one from the other part. So then I always close it, and this harvesting technique has the advantage that I can close this area. So we can theoretically harvest a second time later. You see here the closure. And then you see the tunnel. But again, these are now natural teeth. Okay, so you see the papillae are there. This is, I consider it very important to have the papilla in place. Have a look at the connective tissue, and then what I do is to pull the connective tissue in the tunnel. First, I use some biologics on the root surface, because here the defect went until the apical part of the root. And then the connective tissue is pulled, in fact, inside. It's very important to have a good team, a good assistant, because we need help. They need to pull the graft in the very same moment when I want to have it. So not to pull too hard, not to pull too soft. So it has to be coordinated. And you can also see the situation when the graft is pulled inside just by a metal suture. Then we have to make sure that the graft is not turning, in fact, in the tunnel. And again, we have to move the graft coronally. How do we do it? This is a very simple technique. I just use a sling suture coming from lingually, but I take my time to fix it at every single tooth. So this is very important. Okay, so the suturing technique is very, very important. I put a lot of emphasis. I know that a lot of colleagues, when you show them the sutures, they are bored because they think, okay, the surgery is done. But I can tell you this will give you the final good outcome, the sutures. So take your time for a good suturing without having any tension in your flap. I think this is the key message that I want to tell you. And this is the same whether you work or with teeth or with implants, without having, in fact, tension. And then we just close the flap laterally. You see, this is a so-called lateral coronal modification that I will publish soon. Is a combination of a laterally closed tunnel and a coronally advanced tunnel. So I use an alternate suturing technique. If the recession is very deep, I close it like that. You see, like a very simple way with single interrupted sutures. And always make sure that the graft is not moving. That's very important. So that's why I use this elevator that will guide, in fact, my suture. And this I do alternating the different recessions. Okay. So you see the coverage, and then if we go now on, look at the situation at 2 years, a very nice improvement, and the patient can clean much better. Okay. So this is now what we do in cases where we have teeth. And also in multiple defects, my results are more, lead to more recession coverage than 90%. What about now implants? So we did a screening of the literature that was published in Periodontology 2000, and I can tell you that not much recent evidence is since then published, but I will show you some new studies as well. According to our literature, first of all, we don't have randomized controlled clinical studies regarding recession treatment around implants. Then only shallow defects, 2 to 3 millimeters, can be covered predictably. No data are available supporting treatment of deep and large recessions at implants. So keep in mind this, probably due to the biology behind. Let me show you some studies. The first study published by Rino Burkhardt more than 10 years ago. Here he treated 10 patients with 1 implant. You can see that he used a coronally advanced flap and he over-contoured the recession, okay? He covered it 120%. Look at the outcomes after 6 months. More than 30%, almost 40% was gone after half a year. Not very good, you see? And he's an excellent surgeon, okay? What about some other studies? Giovanni Zucchelli published one nice study, 2013, but here he used a combination of a so-called coronal advanced flap and also a preparation of the abutment. But this is very dangerous because over time it may break. However, with this technique, he obtained a complete recession coverage in 75% of the cases, and mean recession coverage very good, more than 96%. And if you go now and look at a follow-up paper that looked at these studies, you can see that 1 patient was lost, but after 5 years, even more was covered, 99%. It's fantastic outcome. He's also a very good surgeon, but it was a combined approach in rather shallow implants where the implant was placed in an acceptable position. What about another study? Mario Rocuzzo published a study on 16 patients, coronal advanced flap, harvesting the graft from the tuberosity. And he obtained a mean recession coverage of about 90%. Complete recession coverage was in about 56%, a little bit more than the half. And they concluded that this is also a successful approach. But again, they were not very deep recessions, and the implants were positioned in a quite acceptable position. And then they looked at the follow-up evaluation of this patient cohort, and they found out that complete implant coverage was available, was visible in 8 out of the 13 defects. That was about 62%. And mean soft tissue dehiscence coverage was about 86%. That was very good. However, don't forget that they have lost some patients. They have lost, in fact, 3 patients because the implants were lost. So that's very, very important. So not everything is successful. And what about long-term evidence that the soft tissue may positively affect the long-term outcomes around the implants? The evidence is still rather sparse, but we can gain about 1.6, 1.7 millimeter of new keratin as attached tissue. So let me show you our concept. What can we do? If I have this case, so case selection is the most important. Look at this case. This patient received an implant in the frontal area. He lives in the mountains in Switzerland. Nobody sees him, so he was happy with the result. It was not a peri-implantitis. When he was laughing, you cannot see the dehiscence. You see this horrible crown. He was then referred to me for recession coverage. Everything is wrong in this case. So this is impossible to cover. I don't even start because I know that I will fail. So here, the only treatment option is explantation if you want to do something good for this patient, okay? However, if I have small dehiscences, you see this case, 2 millimeters. The implants are placed in the correct position. However, the soft tissue was very thin. The patient has problems in cleaning, and of course, the titanium is shining through. So here, what I use is clean the implant surface, use maybe the EMS, the PerioFlow. You remove the plaque, but I know that we have also better options now in Frankfurt, so I want to learn also those. And then place a connective tissue with a tunnel approach. And this can be successful. After 4 years, about 1.5 millimeter coverage and increase in tissue stability. That's it. It's not a miracle compared to that what I've shown you around the teeth, okay? But it is much more difficult. Another case, look at this situation. The patient has a kind of bone loss facially because the implant was 5-1, but he doesn't have any pockets. Why should I remove this implant? To create a huge defect? Of course, maybe from a financial point of view would be better, but he doesn't have problems. He just wants to have more tissue thickness, and he doesn't want to see the titanium shining through. This is very important. If the defect is a kind of concave-like one, then we can augment, okay? So here I use, again, the tunnel approach. I keep the papillae, place a connective tissue graft, pull it inside, and what I do is nothing else but implementing that what I've learned in periosurgery to the peri-implant soft tissue surgery. And then I can have an increase in tissue thickness. You see that we have more keratinization, and then the prosthodontist can change the crown, and then everything would look much better. Or in this case, again, a large diameter implant, but again, no pockets around the implant. Why should I remove it? I would create a huge defect. What I do here, again, is a connective tissue graft, tunnel approach, and again, I gained about 2 millimeters, okay? Not 10, but about 2. So the patient can clean better, his aesthetic is acceptable. Look at this case. So here again, the implant was placed correctly. Also, bone augmentation was done, but they have forgotten to think at the soft tissues. So look at this small dehiscence. It is a problem because, first of all, the aesthetic is compromised, but then also the cleansability. All the time the patient has some plaque there. So in this case, what I do is to implement the tunnel approach that I've shown you before around teeth to this implant case. I can tell you it is more difficult to treat these cases, okay, around implants, because first of all, it is more difficult to prepare the tunnel due to the fact that in fact, here it was already augmented. And always when you go a second time in the same site, you have more scar tissue. So if you want to make this bridge between the natural tooth and the implant surface, you have to make sure that all the fibers are released. Otherwise, it is a horror to move, to pull inside the connective tissue graft. So then I use a connective tissue. Of course, we have also soft tissue replacement materials, but in difficult cases, in challenging cases, and especially if you are not completely sure that you can close perfectly, then I always recommend to use autogenous tissue. Okay, this is the first choice. So here I pull the graft like a kind of membrane over the surface of the implant, making sure that the graft is not turning. I fix it always at one side, and then I can stretch it to the other side. So in fact, it is nothing else but that's what I have shown you before. You see the mattress sutures. I prefer to use mattress sutures to pull the graft, always coming from the same direction. And I create a kind of membrane or bridge-like structure over the titanium. And then my assistant is pulling it. It's very important to stretch very nicely the graft and then to fix it. We don't have to allow for any mobility of the graft. So that's why, again, the same sling suture. You see, I come with a suture. I start palatally. I engage the graft. Facially, I go around it, engage it at the other line angle. And then I make the knot palatally, okay? So now I have cells. I have connective tissue cells, and these connective tissue cells will create or will enable keratinization, okay? Because they have the genetic information. Then I just try to close the margins of the wound laterally and coronally. Very, very gently, okay? Okay, like that. Okay, and then at the neighboring teeth, I use a coronally moved tunnel. Now everything is stable. This is the big advantage of the connective tissue, of the autogenous tissue. If you have a small dehiscence still, but you have underneath connective tissue, this will keratinize very nicely. Look at this outcome. This is the same crown, nothing was changed, and I was able to close this area. Okay, let me come to some conclusions. I hope that I was able to convince you that these techniques are quite predictable. for teeth, but also for certain cases around implants. We may have some new collagen matrices that may serve as replacement materials for connective tissue graft, but also as scaffolds for biologics. Please don't forget to make sure that you have also attached mucosa around your implants, because this will improve your long-term stability. Very, very important. You want to have these patients for 10, 20, 30 years in your practice. So this is extremely important. What about recessions? I have elaborated on the differences in the anatomy between a tooth, between an implant. And for this reason, the healing is also different. And also we have, of course, the problem of the implant, the treatment planning, that the implants were placed maybe not in the proper position. If you have dehiscences, recessions around implants, the current evidence suggests that we can only predictably cover small defects. Don't try impossible cases. 2-3 millimeters are still fine, even 4 maybe, if the implant is positioned in an acceptable position. But don't try to cover or to improve situations that are impossible, because this will fail. We still have to go a long way, but I think that keeping in mind these messages, you can improve your treatment consent and of course your long-term predictability of your approach. So thank you very much for attending this lecture. If you have any questions, you can write me an email, or I have also a Tony Scully and Perio team in the Facebook team. You can also post me something there. But we have also now the cases. I inserted the cases now at the end. I don't know, do we have a discussion now? Should I show you the cases now from the students?
Yeah, I think we can now have the first questions. And after, let me say, 5-10 minutes, we go on with the cases which are provided by our students. But first of all, we will start with 1 or 2 questions.
Yeah.
Catherine, do you have the names that we call to these guys? Yeah.
Yes, the first question comes from our MOI graduate and MOI tutor, Dr. Yunus Mohamed. You have the microphone. Can you hear me?
Yeah, I hear you. Thank you. Actually, I have few questions. The first question is regarding peri-implantitis. The first question is, do you have or do you see any difference between bone level and tissue level implants? And regarding hex connection versus conical connection, so due to your experience, in case of presence and aggression of peri-implantitis. And the second part regarding the tunneling technique, if you use PRF instead of connective tissue graft, and also before inserting the graft, if you make any mechanical or chemical cleaning to the exposed surface of the implant.
Very good. Regarding peri-implantitis, I think that if you have a tissue level implant, you have usually a more stable situation regarding soft tissues. So it's difficult to give you an answer based on the evidence, but if you look at the Dirks paper and you look at the different implants that were analyzed, then the implants that had a tissue level component had the least prevalence of peri-implantitis, which indicates, and we can also see it in our patient pool, that if you have this polished neck surface, then it's more stable. So we prefer to use tissue level implants whenever possible. Of course, maybe in the aesthetic area it is not possible, but generally we prefer to use tissue level implants. We are more conservative in burn. This can be discussed, but we want to avoid complications as much as possible. And our patients, I would say that 95% of our patients are patients that are have a history of periodontitis, and we know that these patients are a special category of patients. So this is quite tricky. So we want to avoid these complications or to reduce them. You cannot perfectly avoid them, but to reduce them as much as possible. The second question was about, regarding the conical and the hex. But I didn't see much difference until now, but the data are also not very clear, So this I cannot answer you based on the evidence.
I just would like to mention something because if you use tissue level implants, so I think it does not matter really if you have hex or conical connection, because the connection is not close to the bone. But the question was, if you use bone level implant, and then what's the difference between conical connection and hex connection? Then I think it would be difference.
For recession coverage, for recession development.
Yeah, and peri-implantitis.
Probably yes. I mean, if you have the bone level type, then is of course like that. But in our material, I can tell you that 95% of the cases that we have in burn are all of them tissue level. So that's why we avoid bone level almost always, So that's why I'm not very experienced in bone level, because I can only tell you that what we know from the literature. And maybe you have more experience with the ankylosing system in Frankfurt. I think with that system, you have a very good stability of the tissues, according to that what I know, also from other colleagues. Yeah. I don't know, maybe Paul can elaborate on that.
Yeah, the point is very nice to mention it, because in your lecture, and thank you again for these very nice insights of your experience and knowledge, you mentioned about the problem if you place two implants very close to each other. Yeah. And what we see, because our students, because we are more or less not sponsored by any company, they can use for their cases, they have to make 20 cases each. They can use every kind of implant and implant system. So we see a lot of different implant systems with our students, more than 700 now. That if you have a platform switched implant and has a good sealing in between the abutment and the implant, even you place it a little bit more close to each other, which is not perfect, but especially in the lower jaw, in the anterior region, we don't see this bone resorption like you see it in other implant system with the hex. And there's a lot of theory behind and some guessing, but even we don't know the mechanism perfectly, we have the facts. And this gives me some thinking about that this kind of design, which also was published from Duatti 2006, gives the soft tissue the option to have, let me say, because the fibers are surrounding the implant, it's like a ball attachment, and the soft tissue is the ring, which is a little bit more stable. And this is what you mentioned. And especially if you have not always the keratinized mucosa with your nice surgical approach, this thickening of the soft tissue because of this platform switching and about the concavity of the abutment gives the soft tissue more room and volume and stabilize it in a little bit mechanically in this way. And this can be one of the reasons, but there's a lot of mechanism behind, and we can discuss a lot of that, but this is my input to that. But now we handle over to the next question before we go to the cases for the students, what they provide us to discuss too. Catherine, do you name the next question, please?
Catherine,
He had another question regarding PRF.
Yes.
Okay, Jonas, I forgot about that.
Yeah.
You make 4 questions, yeah? No problem. Yeah, we make it. We make it.
Okay. You said you can ask questions, not only one question. Then I'll ask only one.
Okay.
I think PRF is not a connective tissue. Huh? If you want to have something that is stable, then you have to use connective tissue because, of course, depending what kind of type of PRF you use, you can also prepare it in a way that you can pull it like a membrane, but this will fall apart over time. And you have a lot of growth factors, a certain mechanical stability, but you need also cells. And if I have, for example, a case where you have a small recession, maybe 2-3 millimeters at a natural tooth, and you have still keratinized tissue, maybe 2-3 millimeters of gingiva, then you can use in a Miller class 1, capilla perfect, you can use probably also PRF. But if you have a challenging case, let's see, 10 millimeter, imagine the case with the lower canine that I have had, there for sure PRF will not work. PRF would work maybe, or would give some additional benefit if you have a connective tissue and you put also PRF. But in very difficult cases, you need connective tissue. Okay.
Thank you, because I have used a lot of PRF and I was not 100% satisfied with the results. That's why.
That's what I mean. It's a matter of the case selection, and in impossible cases, or if you want really to go for sure, use autogenous tissue. And then, of course, you can also play with endogain, with PRF, hyaluronic acid. You can play with these tools as well. But the first is case selection, proper surgical technique, use connective tissue, and make a proper suture. Okay, these are more important than playing with all the kind of centrifuges. But,
okay, thank you. And my last question was regarding the surface treatment of the exposed implant.
I think that even if, now I didn't speak about peri-implantitis, okay? This is another topic. So this was not the topic of my lecture. But even if I have a recession at an implant surface, I try to clean it a little bit. And what we use nowadays is this erythritol powder, the PeriFlow, because we don't have better tools, okay? Because it is very difficult to use a curette. Sometimes we combine it with a titanium curette, but this PeriFlow is quite okay. And of course, there are also probably a better technique like this Galvano technique that we would like to try, because this seems to be very, very, very good, and you can very predictably remove the biofilm, because if you have bacteria on an implant surface that is more difficult to clean than a tooth, then of course your outcome is a little bit jeopardized. So that's why I think that the first step is to clean it, and then you can do whatever you want, but you need also another surgical approach.
Okay, so mechanical and chemical cleaning.
Chemical, I don't know. This Galvano technique, I think this you can use, but we use the PeriFlow, and this is of course rather mechanical cleaning, because this is not chemical. So we don't use citric acid or EDTA whatsoever. So according to literature, it is not a big advantage if you use that.
So you don't use laser or chlorhexidine?
No.
Or nothing?
No, you can also play with the laser, but it was also not very successful. We used the erbium YAG laser, we used also CO2. You can also use diode laser. But if you compare really the studies, and we did some systematic reviews, and you have also data from Frank Schwartz, it's not a big difference. Even if you take a gauze and you place it in saline and you clean it, it was the same result than with chlorhexidine. So I think that you have to remove the biofilm mechanically as good as you can. And the curette is too big to go in the threads. It's logical. You cannot remove with such a curette, such a small bacteria, as is impossible. So you have to use something different.
Yeah, that's why the chemical is important, because reduce the biofilm. If you don't use reduce the biofilm, so the mechanical cleaning is not effective, I think.
No, I don't agree. I think you have to use it with a PeriFlow is not
okay, now we have to interrupt because otherwise it was a personal discussion. Which was the next name, which has a question to Anton Skulian?
We have 2 more questions. After that, we have to move on to discussion the cases, okay?
Yes.
So next question is from Dr. Pasidi, who will actually join the upcoming MOI class. Michael, you have the microphone.
Yes. Yeah, can you hear me? Is that clear?
Perfect.
Yeah. I'm very thrilled to listen to the lecture. It was very good, and was amazed to see fixing recession around the implants. Just a couple of quick questions. The first one, with the implants, already existing implants with no keratinized mucosa, can we do free gingival graft after the implant have been integrated, or is it a lost cause? That's the first question. The second one, with fixing recession around implants, does it have to be a single implant in between teeth? You can't do it on two two adjacent implants? Yeah, thank you so much.
That's an important question, or 2 important questions. I think that, of course, in many cases, you have already the situation that you don't have facially attached mucosa, so you have to treat it. You cannot remove the implant. The implant is also integrated, but you have very often these cases in the posterior area. So the best is to use a free gingival graft, but not to cover the implant surface, because this will not be successful, but apically. So you make the first incision. If you still have maybe 1 band of attached mucosa, you make it a little bit apically and you fix it exactly to the periosteum. Then you need to have a split thickness flap and you fix it there. So this is the most predictable approach, okay? And then to the second question that you have is whether you have recessions at 2 implants, but then the problem is that if you have these cases, in the majority of the cases, the interproximal papilla is gone, or not completely gone, but it's at least you don't have the same bone support. So this is the advantage of a tooth. It keeps the papilla. In some cases, you can only thicken. Okay, you cannot predictably cover it, but you can thicken it and you still have an improved outcome. But usually, as I've shown it to you, you have already some loss of the interproximal bone. The bone is always determining the height of the soft tissue.
And the other thing, sorry, quickly, with the tuberosity connective tissue graft, do you have bone transformation from them occasionally? Because I have a couple of cases when it actually transformed into bone later on. Is it possible, or it just feels different to touch? That's all it is.
No, I mean, this is very good. Not only the tuberosity graft, but also the palatal graft sometimes. But especially if you use them as a free gingival graft. Okay, if you take them together, and we have now a paper in publication where we have harvested the entire bunch of tissue in block, and we did histology, and of course, it worked like a kind of GBR capsule, and we have bone formation underneath. So it can, but not because of the connective tissue. We don't know the mechanism. One possibility would be that, what we discussed is that you transplanted also the periosteum with the graft, and the periosteal cells have the potential to create bone, or you place the free gingival graft on the periosteum, then you somehow because you suture it to the periosteum, somehow you give a kind of impulse to the cells to create bone. Okay, we don't know what is the proper mechanism, but in fact you are right. It can create bone, and we have demonstrated also in a 3-dimensional image, cone-beam CT, showing that the bone is growing around. I mean, you have the alveolar bone, then you have the periosteum, connective tissue, and you have another layer of bone. And we did it also with the CBCT. Then I harvested the graft, and we did block biopsy. So we have radiographic imaging, and we have also the histology. So you are perfectly right, but we don't know the precise mechanism.
The exact mechanism.
Okay, then the next question, please.
Okay, next question comes from our MOI tutor, Daniel Saad. Daniel?
Good afternoon, everyone. Thank you, Dr. Sturian, for this amazing lecture. I have only one question. regarding the composite filling on the lower teeth on the cervical filling. I noticed that you removed them before grafting, right? So it is like it's a standardized approach that you follow every time, or there is a decision-making tree like the Zucchelli's one that you follow. Can you just explain that?
No, I mean, as a periodontist, I don't like to cover restorations. This is my first thought. I want to have periodontal health. So I know that there are data that have shown that it is possible to cover even a composite filling if you have a recession on a composite filling. But we don't have long-term data. So I don't want to cover a recession and to that has a deep filling, long filling, maybe 5 millimeters. Imagine if you have a leakage there after 5 or 10 years and you have a very nice coverage. So how do you get access there? Only if you raise a flap. So in fact, you destroy that what you have done. So I always remove the composite fillings, but what you can do is sometimes to recontour the cement enamel junction with a composite and you polish it, okay? And then you move the flap or the tunnel coronally until maybe you cover 1 millimeter of this polished area. In this way, you can have a kind of compromise, but not the entire concavity. So I don't place a complete new filling, okay? Even if I have this concavity on the root surface, it is even better, because if you have a concavity, this concavity will stabilize your blood clot. And the problem is always because the convexity. So if I have a natural concavity, then I'm happy because my connective tissue will stay in a so-called contained time defect, and this can have a much better vascularization.
Okay, but it's instead of thickening the gingiva buccally, you are actually stuffing the connective tissue right inside the erosion.
Yeah, that's a cavity, not an erosion. Yeah. Where is the problem?
You are not thickening, actually, from the facial aesthetics. You are not thickening the gingiva. I mean.
No, I mean, you have seen the cases; they are thickening. Yeah. I mean, if you place 2 millimeters of connective tissue in an area where you had the filling, then you have 2 millimeters of thicker tissue. That is thicker.
Okay, thank you.
Yeah.
Okay. Anton, now we have to move to the cases where the students has provided, and then we have some questions from the students to these cases and also to the others, of course. Perhaps you can share the screen again. Yes.
So it was.
Okay. Yeah. Good.
Okay. So.
Yeah, here we see. Yeah.
Should I show this?
Yes.
Should I go back or?
No, I think this is a case where we have very poor situation from the bone, and I think the student want to know, and perhaps he can tell it by. Is this joining the Congress? The student?
Yes, this case was provided by Dr. Vin Nguyen.
Yeah, perhaps he can ask you
Vin,
personally.
if you want to say something about the case, you have to turn on the microphone.
Should I say something or
no? Yeah, okay, Vin, go ahead.
Hello. Yes. This case was referred to me, and the patient is about 70 years old, and he around 20 years ago he got orthodontic treatment to try to erupt his impacted canine. However, the canine was ankylosed, and so the surgeon removed the canine, and unfortunately the area was infected, and so the lateral was also extracted. 2 years ago, a team of surgeons tried to graft the area for implant, but the graft failed. So they remove the graft, they do the immediate another graft, which in turn failed. So now we are left with an area which has the poor vascularized because of the graft particle is still residual graft particles. Also, we have a recession on the premolar which lost the mesone bone, soft tissue scar. Now, if we want to do another graft, in this case would be a vertical GBR graft. I would like to know what is the best, as part of the treatment plan, I want to remove the first premolar too, because I want to take advantage of the distal bone for the improved blood supply. And so I would like to know what kind of incision to optimize the flap closure in this case, because the palatal tissue was thick, but also vertically defected. And that's my question.
But you want to have a vertical augmentation, huh? You want to have a vertical augmentation at the lateral premolar, the lateral incisor, and the canine, huh?
And if we take out the first premolar, we will have to augment the whole area of the three, you know, the three teeth for preparing for implant placement.
But why take out the first premolar?
Pardon me?
What is the reason to take out to remove the first premolar?
The bone on the mesial of the first premolar is also very low. And so if we want to do a vertical augmentation, we would just go maybe around, not much comparing to if we use the distal bone, proximal bone of the first premolar. We could help with the vascularization and have a better bridge for the bone graft.
So probably here you need I think the technique that I know is the most predictable is the technique that has been described by Ishan Urban, you know, the sausage technique, where he used particulated autogenous bone together with maybe some natural bone mineral in order to keep the volume. And the incision should be a little bit more from a palatal side in order to preserve the keratinized tissue, or to push a little bit the keratinized tissue from palatally to buccally. Okay, so I would go for the sausage technique, but maybe there are also some other options, like for example, some colleagues were working with distraction of the genesis, or maybe these meshes, these rails meshes that you can use. This is also quite successful. I think this could also be a good indication, because with that you can obtain a very nice vertical increase in the bone. But the incision should be a little bit more palatally, okay? Because otherwise you may lose some of the tissue, some of the keratinized tissue. And since you have also some granulation tissue in this defect, then you can take advantage of this granulation tissue. If you incise a little bit more palatally, you preserve the granulation tissue that you push facially, and in this way you preserve even more volume for the buccal flap. Okay.
Yeah, I thank you so much, because I was thinking of having incision more buccally. My rationale is that if we do it more buccally, we have a flap which is wider and longer on the palatal, which is not mobile, and then we can use the buccal flap. We can have it more increased mobility, so we can bring it down. I did not think about the lingual flap, because now if we do from the palatal incision after the graft, the incision, the sutures line would be more palatal, Is there any compromise on that?
No, what I mean is not to have a buccal flap, but to make the incision more palatally, and then you, of course, you prepare the buccal flap, okay? But the incision, instead of having it crestally, you incise it a little bit more palatally, sorry. And then you can move the buccal flap even more coronally. Of course, the flap is buccal, is obvious, but you don't go with the incision on the crest, you make it a little bit more palatally, okay? In this way, you preserve more soft tissue for the buccal flap, of course. You understand what I mean?
Yes, yes, yes.
Okay, I have to interrupt to go for the next case, but the final question I add for Win is, what is your final decision, Anton? Do you think there's a must to extract the first premolar, that the plan is from Win, or even because of the nasal aspect, there's no bone you see in the cone beam CT, you can keep it? So in other words, is this kind of situation a danger for the grafting procedure because there's no covering of bone on the first molar, or think it's worth to keep him because the patient is very young?
I would keep the first premolar definitely, but
okay.
This is my philosophy, because I
okay.
think that the rest is the management of the flap, and I think if you can prepare also the buccal flap very nicely, of course here you will need also vertical releasing incisions that you place a little bit more mesially and distally. You can also place the vertical releasing incision at the distal part of the first premolar, and then you go intrasulculary and with the other incision more palatally. The issue is the flap management and not to extract another tooth.
Okay, sorry, we have to go to the next case, which is also delivered from a student. So give us the next slides.
This one?
Yeah, this
I
one.
think this is the case, yeah, from Federico.
Yeah, and please go through because there are many slides, 2 or 3, yeah. So he plays an implant, okay, and finally he ends up with a situation. Next, please. Next, please.
That was the last, I think.
Oh, this was this. Okay, yeah, and so in the first point he has a recession. So perhaps you can talk to him directly. What his question is about his case to you, Federico.
Federico, you have the microphone.
So the issue is the thin bucket.
Hello, can you hear me?
Yeah, we can hear you, Federico.
And maybe you can give us some background about the case and maybe some difficulties you experienced.
Sorry, I can't.
Federico, can you hear us? No, it's not working.
I think there might be an internet connection problem. If you want to, we can move on to Erling's case because he's also here.
Okay, we go to the next case and perhaps
Sorry,
you can...
I'm here again.
Ah, okay.
Sorry.
Good.
Sorry, I couldn't hear you. Maybe it was a problem with the internet connection. Sorry, I cannot also turn the video on. I'm having a problem with the camera. Sorry, what was the question?
Can you hear us now?
Yes.
So we just showed some slides from your patient's case, and maybe you could give some background information to the participants and Paul and Professor Sculian as well.
Okay, so basically this tooth had an horizontal fracture below the gum level, and we decided for the extraction and implant with immediate loading. And I think the pictures you showed after were only after the healing.
Oh, we lost him again.
This was the case.
Okay, Federico, please write it on a chat your question to Professor Sculian. So Anton, go to the next case. Otherwise, we lose a lot of time. and Federico perhaps can chat it or can make it by WhatsApp, and we will do it. So this was a case of the Erling Valdimaressen, which is also a lecturer after you. And yeah, this was the first initial situation, but I think he can comment better by his own.
Yes, hello.
Yeah.
This was a traumatic case. He got hit in the face with some lumber while working, and he broke the crown of tooth 2-1. It was previously restored by some para posts, and there was nothing left of the tooth to build on. So we just decided to remove it and place an immediate implant. You could show the next slides. So this is the clinical pictures of the insertion of the implant and the grafting with the xenograft, and the X-ray of the implant post-operative. I would like to ask you, Julian, if I may, would you graft this with soft tissue also?
Yes, definitely, because in this way you will you will avoid also dehiscence at the grafted site. So what the issue is in this case, what I would have done before is to maybe to keep the tooth at the beginning, to have a tunnel from canine until the tooth number 1-1 or even 1-2, you know, soft tissue grafting, wait for that healing, and then to extract the tooth and do what you did. Of course, theoretically, you could also do it in the same stage, but I think if you have more soft tissue, you can work better also with the implant. So if the patient doesn't have, of course, pain and so on, and the tooth is, of course, not mobile, then you could do it in this way. Otherwise, I would have grafted during the surgery. So you do what you did, but you could extend it in a tunnel with a long connective tissue graft, extending from canine to canine even, no? Because then you improve the overall aesthetic situation, and then do the same what you did. I think you did right, but I think you have still a lack of soft tissue, you see. Okay. And in these cases, in my opinion, it is mandatory to have a long connective tissue tunnel from canine to canine, place a graft, and then the best would be to do it before, but sometimes it is impossible. Then you do it during the surgery, and you did everything right, but a connective tissue graft with a tunnel is missing. And I would use the tunnel technique, because if you cut the papillae in this case, things get more difficult to suture, and the healing is not that nice. So for these cases, the tunnel is very predictable and very good. And if you use connective tissue, then you won't have big post-operative complications.
Thank you.
Okay. Yeah, and then this is also answering the question. Can you go to the last slide from this case? Yes, yeah. Next one. Yeah, on the right side. So now we have a situation. No, next one.
Oh, sorry.
No problem.
I was too fast.
Yeah, as always. No, the last one here. This one. Yeah. Okay.
How can I do it?
Yeah. Okay. So let me say this patient from Erling is showing up next month to you with this outcome. Yeah. And you see now 1-1 is a tooth, and 2-1 is an implant-borne crown, right?
Yeah.
And then the patient, let me say, is fall in love new, and the girlfriend has a problem with this recession. So now you have a recession on the tooth and you have a recession on the implant side by side. Do you use now the same approach? And I think you already mentioned it with this tunnel technique and this grafting, or do you this grafting and recession covering on the tooth and the implant on a different way? So if this patient show up tomorrow in your, not tomorrow, but on Monday in your office, with this kind of wish that he want to get out of these recession problems.
Maybe you cannot get out perfect 100%, but what I will do is definitely, this is a perfect case for tunneling. So I would tunnel from first premolar to the other first premolar, so including the canines, and take a huge graft, a long graft, and cover everything and move also the tunnel coronally. So in this case, I could definitely improve the situation at the teeth. And if I improve the situation at the teeth, then the implant will also improve because I move everything coronally. So this is really the good case for tunnel, but don't cut the papillae. This is the message. Don't cut the papillae. Use a coronally advanced tunnel with connective tissue graft. And this case will turn out very nicely. Maybe not 100% coverage, but even if you obtain in this case 90 or 85 or 80, it is still very good.
Okay, yeah, then I will close this lecture and the question and answer with two of my questions, which are a little bit provocative, because you have to know, and I have to tell all these participants that Tony, also Professor Anton Skulja, gives me not a promise, but a discussion that he will try to join as a lecturer in our program. And I think this will be very, very great, but we will still working on him because he is completely fully scheduled. He has never time, but we'll see. But to give you a picture, in our classrooms, we always discuss different options, different therapy options like you in your lecture, and try to find some literature, or we don't find literature like you too, especially in implants. This is all the reason that we go for this topic, that there's a little bit poor, the literature about recession covering on an implant. And the best thing is to avoid recession. So which kind of recommendation you give in your experience and your literature knowledge after you extract the tooth and you have, let me say, some dehiscence of your buccal plate? So most of the clinician and literature recommend you to place some grafting materials in the so-called distance space between implant and the buccal aspect, and then put a crown on tip. So we talk about immediate placement and immediate restoration in the aesthetic zone with a single. Or is it also, let me say, for you a possible way that you do the same, but without grafting material, putting in only the blood clot or some PRF in the so-called jumping distance space was placed? And so I want to have a short opinion on that, and which kind of party in the implant community you are the prioritization, or you give us this was my first question, and the second one comes later on. Now we will discuss on that.
Okay, so but you mean an immediate implant placement, extraction and immediate implant placement? Yeah,
so the case where we see before, because of the internet connection was go down from Erling, is now from Federico Catalao. He placed the implant and he placed some bone minerals into the socket, and then he placed the temporary restoration of the final one. And this is one of the approach, and the other approach is to do the same but not placing any minerals, only the blood clot will transfer to bone, to native bone. And if you remove the temporary restoration, you always see in the soft tissue this granulars, the white granulars in the tissue, in the soft tissue. And I don't get a good feeling if a patient comes every 5 years and say, "Hey, doctor, there's a problem. There's some white granulars coming out of my gingiva." Yeah, this I have sometimes as an experience. And there we think about perhaps we can avoid it, or of course you can also place some bone chips, native bone chips into this gap. But what is this kind of recommendation of today from you, from your experience and from your literature knowledge?
I think that basically the idea is always to stabilize the blood clot. So if you use, for example, a kind of granules, well, let's say BIOS or BIOS chips or whatever, what resolves slowly, I do not aim a GBR, a guided bone regeneration in these cases, because you cannot completely close. So this is not GBR. So the rationale to use the bone filler is to preserve, first of all, the volume and to improve the space for the blood clot. So in fact, in my rationale, I use the filler to stabilize the blood clot. This is one modality. And I don't like to use the particles. What you use nowadays is just a simple kind of collagen mixed with the particles. This is the biased collagen, for example, that you can use, because the collagen attracts the blood, stabilizes the clot, and maintains the volume. Okay? And if I am able to do this without a filler, but I don't know how to do it, if you find another possibility to do it, I think you have your technique that you have shown a couple of times. I think that's also fine.
Okay.
But I don't place the bone there to get to aim bone regeneration. In these phases, you always want to preserve the volume and to stabilize the blood clot. This is the aim also of the graft.
Yeah, I completely in line with you. But we have learned that if you place a crown on top, which is going into this curve of the tooth arrow arch, the tooth arch, that the pressure of the lip is not so strong on the alveolar ridge, and we don't get this big concavity in the alveolar ridge. Then it's described by Mario Sanch in his randomized clinical trial 2017, because he using only healing abutment on top, and therefore the lip can pressure a little bit more on the alveolar ridge, and then he created this cavity. And we see in our cases this not so much, so we are also going for doing nothing in it, because the stabilizing is very nicely, because there's not a lot of pressure. But we have to see it also in a study which we are now trying to do with some master theses. Okay,
I agree with you. I think I agree with the biology behind, to stabilize the blood clot. I think this is the issue. This is the main issue, and you can stabilize the blood clot in different ways.
Yeah, of course. So then the last question, and then you have to run again in another meeting. You tell me, you're a very busy man. You mentioned in your lecture as one of the reasons for this dehiscences in implants, and we do it also in our school. And we have a lot of discussion, because my students know me, and this is for a long time, that I always recommend the following. You have an alveolar ridge, and you can place, let me say, a 4.5 millimeter implant, and you have still the envelope for 1.5 millimeter or 2 millimeter, what you mentioned. I can also place an implant which has a smaller diameter, let me say 3.8. So then you have a thicker envelope. The envelope is perhaps 2.5 millimeter or 3 millimeter, because you use a smaller diameter. Even you have the possibility to use a wider diameter. So what is your recommendation? Is the smallest diameter, which is possible, even in the alveolar ridge, which is wide, really a good way for this prevention of dehiscences? Of course, the diameter cannot be too small because of mechanical reasons. It has minimal size that the mechanical fatigue and the fracture is avoided. But I see in my students, if they start the program, they have the rationale, okay, I have a wide alveolar ridge, I can place a wide implant. I have a small alveolar ridge, I can place only a small one. But if I have a wide one, nobody will place a small one, okay? So what is your recommendation on that?
It depends also on the implant type that you use, huh? Probably, because I mean, usually in burn, we go for reduced diameter implant in frontal area. Okay,
yeah,
we take it 3.3, or I don't know, there are different systems. And this one we use in the frontal area. However, in the posterior areas, if possible, we don't use the reduced diameter implants. We prefer to go for GBR. And in those cases, we don't use the reduced diameter, because we have experience with this 3.3, and this is a little bit too reduced. But maybe if you have 3.8, I think is nothing against that. I think the issue is, for me, is where you have the polished surface. This should be supramucosal, you know, if you are in the posterior area. I think this is more important than the diameter of the implant, because if you want to avoid complications.
Good.
Yeah.
So, yeah, Professor Dr. Anton Skuljan, thank you again for your time. Yeah. And thank you again that we have you here in this lecture. I think I learned a lot, and my students too, some new aspects, your philosophy, your knowledge, and so on. And I say on behalf of my students and also from the guests coming into this online Congress, many thanks, and hopefully we see us personally again as a friend, and to discuss on a scientific based way on different aspects. And of course, also it's really a wish from me that you join us as a lecturer in the program too. We will discuss again, and I wish you a nice and good weekend, and keep healthy. Thank you.
Thank you. Keep healthy, all of you, and hope to see you soon. Okay. And thank you for the invitation.
No, we have to thank you.
Okay, thank you.
Okay. So, Catherine, then you can announce how we go on. We have first a break, yes?
Yes, we have a short break now. We will cut the break a little. It will be 20 minutes. So we'll proceed at 2:30 with the lecture of our MOI graduate, Dr. Erling Valdimarsson. Erling, we are already looking forward to you. But for now, we can all chill for 20 minutes if you like.
And stay in the Zoom. Stay in, and yeah, we come back in 20 minutes. Yeah, stay in the Zoom meeting room. Then you don't have to go again in. Right? That's much more better. Yeah.
Exactly. See you later.
Okay. See you.
Hi, Erling, can you hear me?
Yeah, I can hear you. Yeah.
Okay, so now we see just your presentation. Can you see your presenter's notes?
Yeah, I can.
Okay, perfect.
Should I also have my video of me, or is that?
Yeah, that would be good.
Okay, Erling, then I will go to the slide for Paul to introduce you, and then we'll go back to you sharing, okay?
Okay.
Hi,
Okay.
Erling.
Hi.
But we'll wait 3 more minutes before we start back with the next session.
That's good.
You have the same tie, huh? So 1 minute more. I think, Erling, 20 minutes is okay, yeah?
Yeah, I think it's about 20 minutes.
Yeah, perfect.
And we're on perfect timing, Paul. So if you
Yeah.
like, you can start with introducing our next lecturer.
Okay. So, dear guys and participants of this MOI Congress, I hope you're all back in the room, in the virtual room of this online Congress. And yeah, it's really nice and an honor for me to introduce you the next speaker. It's Erling Valdimarsson, and he's coming from Denmark, but he has graduated 2004, so 16 years ago in Iceland. And he working first between 2005 and 12 in Iceland, and then he started his own practice in Denmark 2012, especially a focus on surgery and implant surgery. And yeah, last but not least, we are very proud that you are graduated last year in July with the MOI. And what I read in your CV was that you're now currently run 3 clinics already in southern Denmark with a growing referral, colleagues which refer to you, their patients. And perhaps if you have time in the end of the lecture, you can also talk a little bit if the MOI knowledge will help you to grow in this big size, if you have time. But now we are really happy to hear your topic. And you see it also on the screen, the application of allograft versus xenograft bone materials in socket preservation, what we already discussed in the end with Professor Skulian, a volumetric analysis and histological comparison in a split mouse design study, a case series. So yeah, please start with presenting your master thesis, dear Erling.
Thank you very much, Paul.
Good. Now we have to share your screen.
Just had it here a second ago.
No problem. Take your time. We are all relaxed because we are all at home.
Did you find the share screen at the button?
Yeah.
So you do the share screen first.
And then portion of a screen.
Yes.
Yes. And I just have to find the presentation. There it is. Okay.
Yes.
Perfect.
Perfect.
That's that. The first phase is over then. That's good.
Okay.
Dear participants of this online symposium, staff and members of the faculty, Professor Paul, thanks for this opportunity. I'm honored to be to have the chance to speak here today. As mentioned before, I'm an MOI graduate, finished 2019, and I will be presenting my thesis study. The name of the thesis study is the application of allograft versus xenograft bone materials in socket preservation, a volumetric analysis and a histologic comparison in a split mouth design study, a case series. This is a schematic drawing I borrowed from the internet, showing the changes to the bone following an extraction of a tooth. As dentists, we know that the alveolar bone changes after an extraction. This is something we see every day. The physiological resorption of the bone is evident. There are numerous studies that confirm this, and it has been shown that the resorption can be 30 to 60%, or even more in certain cases. One study states that the extraction of a tooth leads to the loss of bundle bone and resorption and remodeling of the alveolar bone. This in turn affects the bone and tissue volume of the side of the extracted tooth. Another study states socket preservation is observed to work with a variety of bone substitutes. The size of the particles does not seem to have any effect on the outcome, but studies show that the effect of the procedure varies depending on the materials used. That is why a comparison of biomaterials in socket preservation is important. There are also studies that show that the resorption can be affected by the method of alveolar ridge preservation, or the socket preservation so-called. Alveolar ridge preservation results in a significant reduction in the vertical bone dimensional change following a tooth extraction when compared to an unassisted socket healing. The purpose of my study was to investigate the difference between xenograft and allograft bone materials in socket preservation, covered with a dermal xenograft membrane, with the hypothesis that the xenograft would show better results in the volumetric analysis and the allograft would be better in the histology. The design of the study was a split mouth design, comparing both materials in the same individual, and the parameters of the study were measuring the volume changes of the alveolar bone and comparing the histology of the two different bone materials. The hypothesis of this prospective clinical case study was the xenograft will be better in the volume analysis of the bone, but allograft will be better in the new bone formation in the histological samples after 5 months of healing. "14 sockets in 5 patients were included in the study. The areas were CBCT scanned before the extraction of the teeth and at the time of harvesting the bone biopsies 5 months later. The measurements were done in the CBCT software and the bone biopsies were processed at the University of Copenhagen. The following slides show one of the participating patients in the study from start to finish. This X-ray shows teeth 1.6 and 1.7, which were deemed unrestorable. This is the slide shows the area immediately after extraction of the teeth. And here we have the immediately after the socket preservation, sockets 1.7 and 1.6. The area of 1.6 is grafted with allograft, and the area of 1.7 is grafted with xenograft. This slide shows the 4 X-rays from start to finish. The 4th one was taken at the time of harvesting the biopsies at 5 months. This clinical picture shows the finished socket preservation of the area with a dermal xenograft membrane covering the sockets, sutured underneath the gingival margin with a 5/0 suture. And I want you to notice the alveolar contour of the buccal bone and around the alveolar. This is at 2 weeks post-op, at the time of suture removal. The picture shows a partial covering of soft tissue over the grafted areas and some exposed grafting particles. At this time, we have a similar volume of both sockets. This picture is taken 3 months after the operation and shows some xenograft particles still being rejected, but no infection or symptoms, just particles that are not integrated. And here we have the picture of at the time of harvesting the biopsies at 5 months. And notice the soft tissue and the volume of the areas of teeth 1.7 compared to 1.6. It's clear that there has been more resorption in the allograft treated socket. When placing the pictures in a row, the volume change is very clear and showing more dimensional change in the allograft treated socket of tooth 1.6. This clinical photograph shows the healed socket at the time of harvesting the bone biopsies and placing the implants. Clinically, it's clear that the structure of the new bone was very different. The allografted site of tooth 1-6 was much more like native bone compared to the xenograft treated socket of 1-7. Here you also can see some particles of the xenograft still very loose in the surface of the harvested area here. This picture shows one of the biopsies and the trephine drill I used for harvesting the biopsies. And this is a picture of the implants in place. Clinically, there was great difference in the bone quality when placing the implants, where the xenograft treated socket had a very loose consistency and low primary stability of the placed implant compared to the allograft treated socket, which had very similar quality as native bone. And the last clinical picture of this case is of the restored implants and the neighboring teeth, but also shows clearly the difference in the volume shrinkage of the two areas. The measurements for the study were done on CBCT scans. This is a screenshot of socket 1-6, the allograft treated socket. A total of 7 xenograft sockets were measured and 7 allograft sockets were measured. Measurements were done on the height of the socket, the mesiodistal width of the sockets, and the buccolingual dimension at the most cervical part of the alveolar bone. This slide is of the same area without the measurements, showing the allograft treated socket of 1-6. And here we have a slide of the xenograft treated socket of 1-7 without measurements, and this is with measurements. Negative dimensional changes occurred at all 14 sockets. The sockets grafted in the maxilla showed most dimensional change, and the posterior mandibular sockets showed least change, as has been described in the literature. The thick cortical bone in the mandibular molar area resorbs much slower than the thin cortical bone in the maxilla. The mean negative volume change of the xenograft sockets in the buccolingual dimension was 1.25 millimeters, versus the negative mean volume of change of the allograft socket was 2.83 millimeters, a difference of 44%. That indicates that the allograft material has a fast turnover and resorbs more easily than the xenograft material. The biopsy was then sent for histological assessment at the University of Copenhagen at the Panum Institute for histology analysis. The biopsies were placed in 10% buffered formalin and decalcified in a solution containing 3.3% formaldehyde and 17% formic acid for 2 weeks. The tissues were embedded in paraffin wax blocks, and then tissue sections of 4 to 5 micrometers were stained by hematoxylin and eosin. This is a table of the histological findings. In the table, it's clear that there is an inflammatory response with the presence of neutrophils, mononuclear cells, and macrophages. In the majority of the samples, no osteoclasts were found. Mononuclear cells and macrophages in the majority of the samples. No osteoclasts were found in the biopsies, but activated osteoblasts were found in all samples except one, showing a clear picture of new bone formation. All the samples showed more than 90% vital bone, meaning that 90% of the autologous bone within the sample was vital. Vital bone was interlocking the bone particles, and some fibrous connective tissue was found between some of the bone particles in 2 of 12 samples. And connective tissue was found at the edge of the biopsies as correlates with the clinical finding of less integration of the graft material at the junction of the bone and soft tissue. This is a slide that shows a tissue section of a biopsy from the xenograft treated socket after staining with hematoxylin and eosin, showing native bone around xenograft particles. The red arrow is the xenograft, and the blue is the native bone. This slide shows a tissue section of an allograft treated socket, and in this slide osteoblasts are aligned between the native bone and the grafting particles, showing an area of bone formation. This slide shows a tissue section of a xenograft treated socket, where xenograft bone particles are interlocked in native bone and also inside connective tissue. This is another xenograft slide. Connective tissue was found at the edge of the biopsies, as correlates with the clinical finding of less integration of the graft material at the junction of the bone and tissue. As conclusion for the histological examination, there was no difference between xenograft and the allograft biopsies regarding new bone formation and viable bone. Both materials showed equal amount of living bone and osteoblast activity, indicating that both materials are of equal biocompatibility and testifying that both materials can function when used in GPR treatments. It can be assumed from the findings, although there are many limitations to the study, that the use of alveolar ridge preservation with both xenograft and allograft material after an extraction of a tooth is a preventive bone resorptive treatment when implant-supported restoration is planned. The mean volume difference was less in the xenograft treated socket compared to the allograft treated socket, indicating a higher volume loss of the allograft treated sockets. This may reflect the higher turnover of the allograft material and the time interval from the augmentation until the sampling of the biopsies, which may have been too long for the allograft material and too short for the xenograft material. This was not reflected by the histology analysis, which did not show any significant difference between the allograft samples and the xenograft samples. Clinically, the xenograft material was more loose than the allograft, and the allograft more compact when placing the implants, and easier to achieve a better primary stability in the allograft treated sockets. The histology showed no significant difference in the viable cells and bone formation, thus giving reason to believe that non-resorbable xenograft particles need longer time to become interlocked in the newly formed bone, and that 5 months is too early for the reopening of the xenograft treated sockets. Both biomaterials tested in this study were osteoconductive and had biocompatibility at the cellular level to an equal degree. The amount of resorption of the two materials differed, and the xenograft showed better results in the volume tests. The results are inconclusive, but interesting and should be researched in a similar bigger scale clinical trial. Thank you for listening.
Yeah, thank you very much, Erling, for this very interesting approach and results, even with histological proof. Yeah, so I think, Catherine, there are any kind of questions listed?
At the moment, we have no questions in the chat. You may also wave to me if you have your camera on. Ah, Vin has a question. So,
Okay.
Vin, I gave you the microphone.
Hello.
Perfect.
Yes, hi. Hi, everybody. I have a question regarding Erling's study. The first question, two questions actually. The first question is there a possibility of having an effect on when the two graft sockets was placed close together? In drug study, we can say that it's like a flow over effect or something like that. Is one drug can affect the other drug in the same mouth. In your case here, could it be possible that there's a mechanical effect by when placing one graft next to another graft, comparing to, let's say, one graft versus an empty socket in terms of volume of the ridge? The second question is that the study has showed that different biomaterial has different length of healing. Let's say xenograft, some we have to wait 9 months, and allograft 6 months. Now, if after 5 months, if the particle is not completely settled, is there any effect on the ridge, final ridge dimension, if the particle is not completely solidified or mature? Thank you.
Can you hear me?
Yes.
Yes. Okay. Thank you for the question. Good questions. I believe so, that if you graft one socket with biomaterial and you leave a socket next to it empty, you probably will get more resorption around the grafted socket also. That's my thoughts about the question you asked. In this case, I have two sockets. I graft them both, so I have a limited resorption of both sockets. Regarding the other question, which was, can you repeat it, please?
Do I remember the question? The timing of the
ridge, the width of the ridge, and the timing of reopening. And yeah, I think the grafted particles, there will be some remodeling of still going on with the xenograft for a longer period of time, but still much less resorption of those sockets than allograft sockets. So I would think that you can get a relatively stable outcome with the xenograft for a longer period of time than compared.
Thank you.
All right.
More questions?
In the chat, there's just congratulations on a great lecture, but no.
Yeah, you get a lot of congratulations. Yeah, you can be proud of.
Thank you.
Yeah, it's very clear and it's an amazing study. So I have to add one question, and this is mostly if you be on stage or even on online, you be on stage. You invested now two kind of materials with different properties, and you find very nice results. But in the end, there is a question. Yeah. If a patient is coming to your office, or you get a referral, or your own father is in the dental chair, yeah, and you have this kind of initial situation that you have to extract a tooth, and you don't want to lose too much bone and soft tissue, I think you go in a dilemma, because with one of the material you don't get a good primary stability, with the other one you lose more volume. So how you solve this dilemma? So what is your recommendation to all these participants? If this kind of situation comes on Monday, to one of your 3 offices?
Yeah, that's a good question, Paul. Thank you.
Thank you.
Actually, if you're going for a stable result, I would go for the xenograft, and I would go for 9 months, for healing of 9 months. But it's not often that you can wait 9 months for treatment. In times today, we want to finish the cases fast, and the patient wants it. So actually, I don't use socket preservation very much in my practice. I use it seldomly, but when I do, I use xenograft particles. And I wait very long. I wait 9 months.
So, yeah, sorry, my next question is what you use instead of socket preservation?
Yeah, I do very much immediate implants.
Ah, good. Yeah. I'm happy. Yeah, because this is what we have also communicate to you, if it's possible, of course.
Yeah.
This is a better way, because patient has not to wait 9 months for the tooth in the gap. They can go home, mostly with a tooth or with a, yeah, okay. But meanwhile, we got some other questions, but let me tell once, yeah, you've seen, we have not a professional lecturer now. If you have an MOI graduate, like Anton Skulian, he can handle very nicely 5 questions from Jonis, and he write down. So please, only 1 question, 1 answer, then 1 question, 1 answer, even from the same, because this is a little bit more convenient for the lecturer, because the lecturer is always nervous, like me too. I'm nervous too. So Catherine, can we have 1 or 2 questions more?
Yes.
I have still time, some minutes, yeah.
The next question is from Felipe.
Yeah.
Felipe, are you there?
Felipe actually wrote his question in the chat because his audio is not so good. He said, in the end, what is your clinical choice of biomaterial?
Yeah, this is the same. What?
Yeah, that's actually, we answered
you
it.
Just answered
before.
it.
Yeah. But
okay.
Yeah.
So then we have the next question from Daniel Saad.
It's coming.
Yeah, can you hear me?
Yes.
Yes, just was wondering if we mix up the 2 materials in 1 socket, if maybe we got more stable or better result. I don't know.
Yeah, I think you would probably get a more fixed, stable result of the material faster than just clear or pure xenograft material.
Thank you.
All right, and then we have another question from Wong Chin Mi. I can also read it out loud. He also posted in the chat. He's asking, now there is a more convenient socket preservation material, ossix bone, which is worth exploring. It's a company from Israel. And now that I'm reading it, it's not a question.
It's facts.
It's not a question, okay. So Wong, I gave you the microphone. If you have another question, you may also ask it. No, maybe he works with ossix bone. Joking. Okay. No, then in the chat, rest of the people say congratulations again, but no other questions.
Okay, then I think we close this kind of question and answer for your lecture. Once again, thank you for your time, for your effort that you present your results here to this MOI family and this Congress. And yeah, I hope you will be very successful in future to open more and more offices. So you infiltrated the whole Denmark population with your offices. And yeah, I hope we see us personally soon. Early,
yes,
yeah?
Thank you. Thank you for having me.
Okay, good.
Thank you very much.
So now we come to the next lecturer. I think all of us which are going for these alumni meetings and so know him. It's Dr. Wingai Bnungian, and he is graduating in Montreal in 1987. So 2 years earlier than me. So he's really a very experienced one. And 6 years ago, 2014, he finalized his study here in the MOI program with his master thesis. And since 6 years, he's really pushing us and giving a good ambassador job, and he's also a tutor. So this is a dream of every program director to have this kind of ambassadors, not stopping doing research after they finish the master thesis. They're going on and also going on for lecturing. And I push always my students also to invent something if they have an idea, and doing this very long and difficult way to realize it. And he realized one of his invention. This is called the Peri-Implant Inhibition technique for ridge preservation and immediate placement. He already published it in a very nice ranked paper. And he is also the founder director of the Montreal Society of Implantology, meaning that he is also organizing a very, very nice alumni congress last year in Canada. So his topic is presenting updates to his research. His topic now is inhibit this, whatever it means, application of the PI technique in complex dental rehabilitation. Please win. The stage is now for you, the virtual stage. So please share your screen, and we are really eager to hear about your new insights and experience and results for your great inhibition, periostal inhibition technique for ridge preservation. Okay, so you have to find also your presentation. Yeah, we see it perfectly.
That's great. First of all, yes.
The first slide is already on the screen. So please, and also 20 minutes also for you. Please try to keep this time.
This time I will try.
Okay.
First of all, I thank you, Paul, so much for letting me allow me to speak in front of Congress. And congratulations and thank you for this MOI staff for organizing this traditional meeting, even during our difficult time. So today's topic, it's not a study or anything, it's just a few clinical case update to the PI technique. And it will be clinical applications of the periosteal inhibition technique in complex cases. But first of all, I would like to explain briefly how the socket preservation technique works for those who are not familiar with this. So PI is a socket preservation technique aiming for on preserving the buccal bone plate while allowing the socket to heal naturally without any bone graft. In this technique, a high density membrane is inserted between the bone and the periosteal and placed for 4 months during the formation of the bone, host bone within the socket. And a gel, gelatin gel, gelatin form of sponge is placed inside the socket just for stabilize the blood clot. The advantage of this technique is that it allows natural bone formation within the socket and not grafted bone. Often we don't need a soft tissue graft either, because if the original position of the gingiva is not modified. And this is the ridge dimension at 4 months post-op. And with this technique is typically, we can see the intact buccal bone, cortical bone forming 90-degree angle with the occlusal surface bone. And in this is X-ray after 4 months. We see a sharp corner forming by the two surfaces of the buccal bone and the occlusal bone. It just may be an indication that the buccal bone plate is remained intact. So many people ask, why did I come up with these questions, this idea? This come from this study, reading this study by Araujo in 2005, and a longitudinal, the historic data show that the presence of the high number of osteoclasts concentrated on the outer surface of the extraction socket during the healing. And we don't know the reason why there is an accumulation of the osteoclasts, but these bone are resolving the buccal and the lingual plate with a very high rate from the early healing of the socket until many months after the formation of bone. The result of the lost bone place is more significant on the palatal, on the buccal aspects. The majority of the socket preservation deal with this intra-socket grafting, as presented by earlier, and no one has mentioned how to prevent the activity of the osteoclast on the outer bone wall. So what do we know about these cells, osteoclasts? This is a bone biology model, and we will focus on this area of the bone resolving phase. When there is a signal, such as a signal of damage from the periodontal ligament in an example of extraction socket, undifferentiated monocytes migrate from the blood vessels of the periosteum to differentiate into the pre-osteoclasts. And only after these cells landed on the surface of the bone that they will communicate, they will migrate toward each other to form a multinucleated osteoclast to initiate a resolving phase. And the size of the precursor is 9 microns in diameter. So my theory is that if we place a PTFE membrane with a 0.3 micron pores, we will prevent these cells from reaching the bone surface to become osteoclasts. And while the membrane allows the nutrition to pass through to nourish the bone. And so our pilot study on periosteal inhibition technique was published last year in the Journal of Periodontics and Restorative Dentistry. And so somebody interested in full text of this, please email me. As with the majority of socket preservation techniques, PI technique can be used as a socket preservation for delay implant placement, or it can be used for immediate implant placement. I will now present the application of this technique in 2 complex cases, which were completed more than 2 years ago. The first case is this case here, a 42-year-old patient with a failed retained canine on the left side due to infections. The canine's prominence in this case is usually very difficult to preserve because we lose the buccal bone rapidly after the extraction. And as we see here on the implant on the right side, the canine implant. So the treatment plan here should be maintaining the contour of the canine as much as possible for aesthetic. So to make the matter worse, the permanent canines are impacted horizontally under the floor of the nose. The left impacted canine can interfere with the implant's placement. So we see here apical erosion of the cortical plates by the apical abscess, which leave with the thin band of marginal bone. And I have a choice here to use a short implant, or we can use a longer implant using go through the canine for mechanical retention. But by doing that, we have to go through a large follicle space, which I'm not very confident. So I decided to remove the implant, the impacted canine, and place the immediate implant with the periosteal inhibition technique to preserve the buccal, the thin buccal band of bone. And so this is the palatal flap was raised and the canine was exposed and sectioned and removed. And this is an empty space that was left by after the extraction. The immediate implant of 3 millimeter and a half diameter was placed with the empty buccal space at around 3 millimeter. A gel form was placed in the socket just to stabilize the cloth. No bone graft, of course. A membrane was placed between the bone and the buccal flap under the periosteal and suture. You can see here the suture that hold the membrane in place. This is after 4 months. I put a larger healing abutment. The contour seems to be okay. And this is at the time of final impression. At this time, we remove the membrane by a small incision in the vestibule and just pull the membrane out that way. And this is the result. This is a final crown after 2 years after the installation. So we have obtained a proper rich contour, and this was done with no bone graft, no soft tissue graft. I will present the second case. The patient is 22 years old. She wore partial dentures for many years. And when the teeth in the upper left quadrant failed, a periodontist removed the teeth and did rich preservation. She came to see me because the previous team could not give her a definite treatment plan for the right side of her mouth. And we present this treatment with the lower right quadrant. This is a premolar area. It has a mobility and recession with poor crown and root ratio, so I decided to include that in the treatment plan. Also, this implant implant here is necessary to use as abutment for the 3-unit bridge because the mental nerve proximity on the second premolar is very close to the surface. This is a second premolar, and you see that it's not a good idea to put implant in this area here. And this is the molar area. We have very short bone height. In this case, you can put a shorter implant here, but I don't feel comfortable to put a short implant to support a 3-unit bridge in this case. So we have the situation is that the advanced vertical bone loss with minimum attached soft tissue, vertical GBR was planned, with non-resorbable membrane. An option here was to remove the first premolar to fill the socket with graft material at the same time as the posterior GBR. But by doing so, I would not have been able to preserve the thin backbone bone plate. And I hope doing that, I often had to do additional bone graft. So in this case, I did a temporary partial extraction while waiting for the GBR graft to heal. The crown of the tooth was sectioned just a bit apical to the gingival margin. A denting screw was used to support the PTFE membrane so that the graft particle doesn't migrate mesally near the nerve exit right here. A flap. We do a flap mobilization. And this is the graft. You notice that there is no bone graft backbone to the first premolar, and the membrane was cut far away from 5 millimeter away from the axis of the mental nerve. And this is X-ray immediately after the graft. This is after 9 months post-op. I had to do a soft tissue graft to augment, to increase the keratinized tissue in this case. And this is the area is ready for the membrane removal and implant placement. At this time, we remove the first premolar root. We obtain decent width of rich width and height. You notice a paper thin backbone plate on the premolar. I decided to do a periosteal inhibition technique here. 2 implants was placed, 4.1 millimeter in diameter. The backbone, the empty space was filled with blood clot alone, and a periosteal PTFE membrane was placed on the backbone bone between the bone and the periosteal. And this is after 4 months. You notice that the soft tissue on the premolar done by periosteal inhibition technique was a lot higher than the soft tissue thickness on the molar. And we place a meso structure for a screw retain bridge. And this is a final case with X-ray. And this is a X-ray that recently taken 2 years after the installation of the bridge. So in conclusion, that with proper planning, the PI technique may be a good option to be used in a variety of more complex situations involving immediate placement. However, keep in mind that a further evidence is needed for this technique to be applied in a routine clinical practice. Thank you for your attention.
Yeah, Wayne, great. Absolutely exactly in time. And thank you for your cases showing our participants. And yeah, Catherine, do we have questions? I think so.
Yes, we have a question in the chat from Felipe. Felipe, you have to take the microphone. Because I tried to give it to you, but you still have to say yes. Felipe says he can't, so there's like a technical problem. but you can post your question in the chat. I see it. Felipe is asking, why did you not make a provisional on the first case, the canine one?
Provisional temporary restoration, yes. Yes. I may be would be able to do it, but except that is the palatal surgery was very extensive, and there is I did not try to expose my patient to another like an hour to do the temporary restoration in that case. I would just like to close it and so the whole surgery is around like 2 hours, but that's it. That's just a personal reason. We have enough stability to do an attempt to. The patient is not really interested to have it immediate provisional right away. I understand it would be good to do an immediate provisional right away, but in this case, because of time constraining.
Mm-hmm. All right. Then the next question is from our tutor, Dr. Jonas. You can go ahead.
Yeah, thank you. It's really a nice lecture. But in the first case, you did show us in the molar, you placed the collagen plate, and then you made re-entry and you removed the plate. Why you do that? Why don't you keep the plate inside if it's collagen plate, and then you make re-entry and then you might have recession again?
Could you repeat that? It's the first case, impaction of the canine, the second case has the molar.
No, yeah. In the molar, you place the collagen plate buccally, right?
Collagen
plate. What
kind of plates?
Or I know kind of plate you placed a material buccally from the buccal side to maintain the buccal wall, right?
Not on the molar, only on the premolar.
And the premolar, so it was premolar.
Yes.
What kind of material is this plate?
Ah, you're not familiar with the PAI technique?
No, I'm not.
Yeah. The PAI technique, like I said before as an introduction, it's a membrane is a PTFE, a high density PTFE membrane. We place it against a buccal bone plate under the periosteal. This reason is to inhibit the migration of osteoclast precursor to migrate onto the bone surface, because only when they touch the bone surface, they fuse together to become osteoclast. That is my theory, is that when we make a screen, we block that, and there's no osteoclast formation on the buccal bone. So I observed that by doing that, the buccal bone is pretty well preserved. As you see in this case, the very paper thin buccal bone, and we just observed by the volume, because I did not take the CBCT. In Canada, it's not just, you cannot just take CBCT just to verify anything, but it preserved pretty well.
Okay, thank you. And do you think that you can find another material which we can keep it inside then to make re-entry again?
Up to now, resorbable membrane, because resorbable membrane, if you can find a resorbable membrane that can last for 4 months, because 4 months is the time that needed for the bone, natural bone to be mature inside the sockets. Now, I have the impression that at that time, the signal is very slow for the resorption of osteoclast. Up to now, I have tried many different membrane, and none of them works except the PTFI. Because the membrane, also resorbable membrane, the pore is too big.
Okay, thank you very much.
Okay, there's another question in the chat. It's from our MOI student, Thomas Streikos. Thomas?
Hello, everyone. Thank you for the great lecture. I would like to ask about the last case. Dear doctor, could you explain about the abutments? Are these multi-units? And do you use these for small bridges? Could you explain more, please?
Yeah, Thomas, why are you moving around?
I'm standing.
Yes, this is Strawman's version of a multi-unit abutment. I just want to use that when I have a bridge, just eliminate the possibility just to have a passive fit to make a screw-retained bridge. The disadvantage of that is sometimes I choose the more slender immersion angle, and so it's higher than the gingival contour. So I use it in posterior because you can see it has a bit of a dark area shining through. Is that does that answer your question?
Yes, thank you. So is it safe to use it for one-side bridges like that? Don't the smaller screws break or something?
This should be done when you feel that you have a larger span bridge, or you shorter bridge, but with that you're not sure that you have enough, you provide enough parallelism. This is just to make sure, it's just a multi-unit abutment to make sure that you have passive fits.
Thank you so much.
Thank you.
Thank you very much.
All right, so in the chat, there's no other questions right now. So Paul, I would give the next no. Now there is a question right this moment. So the next question is from Dr. Moeen Shirazi. I gave you the microphone. Yes, looks good. Hi.
Hello.
Hi.
Hello. We can hear you.
Okay. I would like to thank you for your nice case presentations. They were actually very useful for me. Do you hear my voice?
Yes.
Yes.
Okay. As a prosthodontist, I always encounter two problems of posterior bone deficiency in height. And I'm sometimes, I am obliged to change the treatment plan to use removable prosthetics, for example, implant supported overdentures instead of fixed prosthetics. And I would like to ask you that how much bone do you anticipate we can gain through this technique that you presented in the second case? How much bone in height can we gain?
Yeah, the bone graph is not a major part of my presentation because we try to introduce a technique on the premolar, which is peri-osteal inhibition with a membrane. The posterior area, I use it like a vertical augmentation, a technique that I learn a bit from everybody, including Dr. Isvan Urban. So usually in this case here, actually, it's about 5 millimeters of augmentation. It looks like significant comparing to a beginning, but it's with the height and with additional bone width, we have enough bone volume to put implants there. It's a very stable technique. It's very good. It's documented, and I have good success with this technique.
Okay, I want to know that how much bone in height when a patient has, you say that it's impossible to put a fixture here. And what is the minimum bone height that you risk to take this operation?
Anybody have an opinion? I heard in some report that they can go to like even 10 millimeter with Dr. Urban.
Because that's a determining factor in prosthetic treatment planning.
Mhm.
We sometimes are obliged to change the treatment plan to a removable one
Definitely.
because of the
Yeah.
posterior lack of bone
We
height.
have a lot of options, and in the case that if you have a mental nerve, the mandibular nerve that's really close, like 2, 3, 4 millimeter, usually I have to consider like you know, all on 4 or something more anterior, utilize more anterior. As any kind of a treatment plan and treatment technique, you have risks that you have to consider. So it's basically a case-to-case basis. You cannot just say, okay, automatically you have that bone, you can augment 10, 15 millimeter of bone. I have not done a case that I go to 15 millimeter of bones, you know, and 10 millimeter of bone is really a rare case, actually, in my under my hands. But 5, 6 millimeters, we can do quite a lot. And plus the residual bone, let's say, like in this case, about 7, 8 millimeter, I think that's sufficient to put implants there. Yeah, it's just case by case, and I'm not an expert in vertical augmentation, so that we have to, you know.
Thank you for your response and your time.
Thank you.
Okay, so last question for Vin comes from Dr. Weigel, actually.
Hi, Win. Thank you again for these nice cases. If you the second cases were challenging, and we have also discussed if it's necessary to extract the premolar, but I was really astonished about the result. However, what is your experience? If you have, let me say, 10 this kinds of cases, 10, and you place 10 times these screws for the tenting and place the PF membrane, how often you will get some dehiscences? Because if you have a dehiscences of this membrane, I think this will challenging also your results and perhaps sacrifice the results. So what is your experience in these complex cases that you have a dehiscence, and what is you're doing if you have this kind of situation? But make it short because we are running out of time.
Yeah,
only 2-3 sentences.
Dehiscence is reported like as high as 30-something%. So dehiscence in this kind of in PTFE membrane is very often encountered. In my practice, it's like about maybe 15%, because the flap mobility is a very important and sutures a very important determination factor. However, dehiscence happens, and I don't worry about that. If I see the dehiscence, I will maintain it. It's not usually it's a small adhesion, and then it's get larger with time, and then plaque accumulate on the membrane, and it just pushes everything around. However, this membrane, a high density membrane, has ability to prevent the bacteria, which is very large, from entering the spore. So in this case, yeah, I can leave it until I find that it's really exposed, and it's usually I waited for 9 months, but if it's 4 months, I can just remove it, or even 3 months, and then just close and just let sometime the even like exposed area, the denuded area, to heal itself. I just close the flap, and because usually under the membrane, after 3 weeks already, we have like soft tissue healing. And so it just the membrane to stabilize the bone graft under, we might lose it. You have sometimes you have infection that have very locally affected the area, but not you. I don't usually see the whole graft that I have to be.
Okay, so thank you again for your time. And now, Catherine, I think we have the last short break, right?
Yes, we will have a last short break, about 10 minutes. So we meet each other again at 15:45 German time to hear our last lecturer, which will be our tutor Daniel Saad. So everybody, as always, you may stay in this room, and we see you in 10 minutes.
Thank you.
Thank you, Vin.
Thank you. Thank you for your attention.
Catherine, give me the sign if we can start.
Mm-hmm. Yeah, I'm not sure if Daniel is already back. I think we wait another minute more. I'm actually not sure if Daniel is having some technical problems because the system just told me Daniel will start his video later. So I think we wait another moment more.
Yeah, because perhaps you can phone him. What's going on? If you have a phone number. I think I have one. Let me look.
Yeah, you do.
He entered the room a few minutes ago, but now he's not there.
No, he was there a second ago, but I think he lost connection.
Okay. There he is.
Yes, he's back.
He's back? Okay.
Yeah.
Okay, so Daniel, we can see you.
Daniel, your microphone is off.
I think he connected from his phone. Okay, yeah,
No,
now
no.
we can see and hear you.
Okay, thank you.
Daniel, you are ready to go?
Yes.
Okay. So, give me some minutes for introduce you.
Yeah.
So, you're the last speaker of this online congress. Thank you very much for your effort and your time. Dr. Daniel Saad obtained his degree of Doctor of Dental Surgery in 2006, so 14 years ago, from St. Joseph University in Beirut in Lebanon. And 2009, he completed his 2-year residence programs in France, where he learned also about laser treatment. And of course, 3 years ago, he's graduated with our Master of Science in Oral Implantology from the Goethe University. And still also, like Win, he is supporting us a lot as an ambassador and also as a tutor. He holds a private office in Beirut, Lebanon. And of course, he has a special interest in guided surgery. So Daniel, we hope that the blast we're all shocked in Beirut, in the Haber, is not affecting your home and your relatives, your family, and of course also not your private office. So I will looking forward for your presenting the digital planning and implant dentistry about a case. So we're looking forward to see your case and discuss it with the rest of the participants. Okay?
Okay, thank you, Dr. Weigel, for giving me this time slot. I have to share my screen now.
Yes.
Is it okay? You can see it?
Yes, it's very nice.
Perfect.
Okay, so just some minutes about or seconds about the blast. You remember we went once, Dr. Weigel and Catherine, to take a drink on a rooftop, if you remember. So this was somewhere here, okay, and the blast is here. It's like less than 1 kilometer. So all the street is demolished. There is no pubs and no restaurants anymore in the street. It looks like something like that. And we were been drinking having some drinks here somewhere on one of these buildings. So yes, this was a very big blast, and we are still under shock. But thanks God, our families and businesses and homes are okay. Now, the lecture will not be that scientific as the previous lecture, so I want to talk about an interesting case that was done last year. So it's been like almost 1 year that I've done that case, and since then I think a lot of improvements and in the techniques and nuances have been added. So let it consider it as a pilot case where some mistakes are allowed. Okay, so this is the case. The patient, she has a long face syndrome with a long lower third of her face, and this is how she smiles. We can see her gummy smile and the crown, which are in bad condition, and also the inflammation of the gums. Now this is her profile. You can see a convex profile with a retracted chin and a double chin, and again a long face syndrome. And this is how she smiles again. Okay, and now this is her intraoral condition. You can see that she has a deep bite and a lot of hopeless teeth with inflammation everywhere. And she was complaining of bleeding gums, bad breath and occlusion, and inability to chew normally, with, of course, social concerns. This is her X-ray. We can see a lot of abscesses almost over every tooth, and she was fed up with the treatment. She has redone the root canals and crowns several times, with ending up with this result. And it was agreed that we extract everything and consider an implant treatment. Having this done, I tried to achieve this result. These are temporaries. It's not final prosthesis. And this is her profile, which has significant improvements, like the improvement in the convexity of her face, the diminishing of her double chin, the advancement of her chin here, and a more pleasant aesthetics. So I will show you in how many sessions I achieved this treatment. I'm gonna skip this. Okay, when we talk about restoring using implants maxillary arch, usually if we go and dig a bit the literature, we can see that the most of the concerns of the articles and the clinicians and researchers are focused more onto atrophied maxillas and not excessive maxilla. And I found two different studies done by two different authors, which who actually agrees on the same classification, more or less. So if we start with the class 3, where the loss of the maxilla is minimal, both of the authors are suggesting such design of prosthesis, of cross-arch prosthesis, which is similar to the prosthesis which we are doing over natural teeth. Okay, so this is the crown design, and it suits the class 3, which has minimal atrophy. When it comes to moderate atrophy, we have some soft and hard tissue loss, and we have to replace it or compensate this loss with porcelain, with pink porcelain, in order to compensate this loss. And then when we have a class 1, which is extremely or severe tissue loss, this kind of patients requires an overdenture, because they require horizontal flanges or over contour here in order to reestablish their facial and lip aesthetics, in order to push back or push away a bit the lips. And in this case scenario, screw retained or cemented bridge over implants are prohibited because this is a plaque or in full retentive prosthesis. They have to be only retained, so the patient can be able is able to remove this prosthesis in order to flush away and clean the integrity of the prosthesis. Otherwise, it will compromise the peri-implant health. So what about the gummy smiles? Like in my case, luckily, this author, Bidra, he has done an extensive effort in the literature studying such cases, and he has dedicated a class 4. He has a class 4 in his classification, which is dedicated for those patients who have gummy smiles, and he proposes to actually convert this class 4 into a one of these classes by doing an osteotomy. Okay, and he showed it again in the in another study that he is doing this conversion from class 4, which is gummy smile, into a class 2 patient, suggesting him this kind of prosthesis, which has a porcelain, a pink porcelain. And I agree with him because this is the class 3 is, if we convert class 4 into class 3, it will be very challenging to manage all the scalloping and this festoning of the gingiva between the crowns, because we don't have any teeth. And if we go to the class 1, I think the patient would not love to have a something like that, like an overdenture, which feels like he has a denture. So the best case scenario, I think it will be a class 2 for me as well. Now, how it was treated. The planning maybe took me two weeks, I think, at least. So I followed this full digital protocol, which has been introduced by Francesco Mangano. He is one of the founders of Digital Dental Society, and he has registered his this protocol: scan, plan, make, done. So what do we have to scan? We have to scan all the data of the patients. Then we have to plan how to do our surgery and to provide future teeth, and then we have to make them. It's either 3D print them or mill them, and then we have to implement this into the patient mouth. So 4 steps. We will start. We will enumerate every step. Okay, let's proceed with the scan. So what do we have to scan? Of course, we have to scan a cone beam CT. To have a cone beam CT, and everyone knows that such cases at least requires a cone beam CT. Then we need study models, and in case of digital dentistry, these study models have to be digital, so an intraoral scan, or we can just scan an alginate impression or a silicone impression, and then we have to also do a facial scan. And then once we have these 3 scans, we can combine them and having it in we combine all the 3 scans and have something called virtual patient, and it has been stated a lot of times in the literature, and this is also a very nice article, which is a very short article in order to see how to stitch all or to align all these or to combine all these scans. So what are the features of the facial scans? It's not only to show it to the patient that I'm a very fancy doctor, but it has a lot of advantages. First of all, you can, after having stitched everything, you can assess the maxilla and your incisors in relation to the lip, and to the midline, and to the lip at maximum smile, and to the lip at here at the rest position, and also you can assess any cant of the jaw. Also, a very interesting advantage or virtue is that you'll be able to mount the whole case on the articulator. Because you can see here approximately where's the condyle, and you know also the infraorbital edge, and then you align this case according to horizontal plane. You align these 2 points with the horizontal plane, and you will have a decent articulator mounting like that. So this scan is done. Now what we have to plan. First of all, we will start with the maxilla. So D2D pictures, 3D pictures, and the virtual patient. Then we will proceed with the smile design, and then after doing the smile design, we're gonna plan our implant accordingly to the smile design. So it will be a prosthetically driven planning. And so let's start with the smile design. Again, this is the baseline. This is the patient, and this is what is according to my conception, what is the optimal maybe tooth position for this patient. We're gonna skip all these details on how to do a smile design. Then also again in the articulator you can place verify your planned occlusal plane, which is here, was done to be parallel to the camper plane, and then you assess also if you have planned your midline according to the face midline, and you can assess also here the incisor at the rest position. So all of these are the advantages of having a facial scan. Now, in order to, so this is the baseline, and this is how the patient should look like. And in order to accommodate this set of teeth, we have to cut away or cut off a segment of the maxilla in order to push in the upper direction the occlusal plane and the teeth. So again, if you can see here in the picture, this is the baseline. Oh, sorry, this is the baseline, and then this is how we have to cut the jaw and then position the our set of teeth. Now we have to do an implant planning after having done with the smile design. So my implant of choice was at this time is such an implant. I don't know if you are familiar with this macro design. I was very skeptical first, like maybe 2 years ago, to try this one, but then I started to be convinced, and until now it's becoming my implant of choice for full arch or cross arch prosthesis. First of all, it is a solid abutment. It doesn't have any hollow inside, and then we are actually by using it, we are avoiding this component, and we are avoiding automatically a micro gap on the bone level. So this implant is a solid abutment, and it has a multi-unit on top, machined multi-unit on top. Okay, and I have seen also a lot of implants starting to do this macro design and to promote it. Let's see all the advantages of such macro design. It is a solid implant. That means that it doesn't have any hollow inside, and since it doesn't have any hollow inside, the manufacturer can manufacture it way thinner, okay, because there is no hollow, and keeping the same mechanical properties. And since it is thin, it is micro-invasive, it is more versatile, and sometimes we can avoid bone augmentation, and we can sometimes also do a nerve bypass. From the implant abutment point of view, it is a tissue level implant, so we are displacing currently the micro gap and the micro movements. It has an external connection. That means that it can compensate accesses, and in this case, it can compensate or tolerate up to 60 degrees of divergence. So if we have two implants divergent by 60 degrees, we can still screw retain decently a prosthesis over it. And so it is screw retained. We are avoiding cementitis, and I think also it is mandatory to have cross-arch prosthesis to be easily retrievable, because in order to maybe do maintenance or to see what's going on sometimes under the prosthesis. So for me, the cross-arch prosthesis has to be removable. It has also a bulky screw in comparison with other multi-unit abutment. Look at the diameter of the screw, and since we know that such connections they only retain the prosthesis by the screw and not by the friction. So all the stress will be on the screw, and that's why I think this was very wise from the company to do it larger than the other multi-units. Okay, so now this was my implant planning. I planned to place 7 implants. As I said, it was like 1 year ago, and I was new to these implants, and I was not very sure if they're gonna withstand the loading. So I placed 7 or instead of 6, let's say. And this was the configuration. And I want to draw your attention here to the these 2 implants. They were pterygoid implants. And also I want to show you that these implants are very anatomy adapted, because they have large threads here on their body in order to engage and compress the tuberosity, which is extremely spongious. And then we have this thin part, apical part, which will engage into the pterygoid plate without a lot of drilling. You just do a pilot drill, and you don't have to drill the pterygoid totally. You can just do like a small drill, and then this implant will engage itself and perforate the cortical of the pterygoid. So this is how the future screws will emerge from my implant, from my teeth. And then this is how also on the panoramic X-ray, I can show you the simulation of my implant planning. And I try to avoid, in such cases, I try to avoid placing the implant in the anterior region, because in such cases, usually I feel that I will have to provide an over contour or a flange in order to support the lip of the patient. So I try to avoid placing implants here in order to not to compromise the peri-implant has in the future. So if a flange will be needed, the prosthesis will go, the contour of prosthesis will go that way, and then we go up here to do an over contour to the lip support, and then go down again and follow the implants. And I think this is very important. Now, finished with the maxilla, we will start with the mandible. It is the mandible actually was planned together. The mandible and the maxilla were planned together before the surgery. So here we have an additional component, which is the vertical dimension. We have also to do a smile design for the lower teeth, and then to do an implant planning accordingly. But I took advantage here of the digital knowledge, if you want, and the softwares to try to manage also the vertical dimension. So again, if we go back to our articulator, we can see that here we have aligned this patient, and we have added the lateral ceph, and you can see how accurate actually the scan and the lateral ceph are. They are totally accurate, and then we can see also our future occlusal plane and our future set of teeth that I planned. And now we have to do something to the vertical dimension, because as we said, she has a long face syndrome and a very long here lower third part of her face. And if we do a basic orthodontic measurement, which is the palatal plane to mandibular plane, we're gonna get a measurement here for this case 39 degrees, and the normality is actually something between, according to literature, something between 20 and 30. So we are 9 degrees away from the upper margin of this of these values. And what I have done, I tried again virtually. I tried to lower the incisal pin by 3 centimeters, which is actually the most I could do in the software. And when, of course, you can hack a bit the software and go deeper, more than 3 millimeters. But I said to myself that that these 3 centimeters were enough. So when I lower or shorten the incisal pin by 3 centimeters, I will get a divergence of 32 degrees, which is only 2 degrees away from the upper margin from these values. And I said to myself that it's okay. I will not go further. It will be like 6 to 7 degrees of correction, and I considered it's enough. So this is the baseline. These are the both of the jaws at the baseline, and here this is my planned set of teeth of the upper jaw, and we have this is her actually before lowering the shortening the incisal pin. This is her baseline occlusion. Okay, and then when we lower, or I lower the incisal pin by 3 centimeters, I will get something like that, an impingement of my lower arch into the newly planned aesthetic piece, upper piece. So I have to remove everything from here in order to accommodate a set of lower teeth. So I have to cut away a certain space and to fit in a lower denture. Okay, so this is how it should look like. This is a simulation after having planned an osteotomy and placed a lower denture. And the implant planning, again, the same implants. I placed 4 intraforaminal implants and 2 short implants in the back. And this is how she should look like with the prosthesis. And now I would like to show you also that you can send actually on WhatsApp if you want, or by email, a smile simulation to the patient. You can send it. This is the before, and this is after. Okay. So you send these 2 files, and she can open the link. And then we have to proceed to the make. What do we have to make? We have to make, first of all, the bone reduction guide. Look at the amount of the maxilla that we have to remove. Then, after having reduced the jaw, we have to place a drilling guide to place our implants in a guided manner. And then we place our implants like here. And then we place something, a gasket or a spacer with indexes. You can see here 2 spikes and a square with the straight angles that I designed. So this will be like locks for my denture, because the denture will have these offsets for these 2 spikes and for the square with the right angles, and you will be sure that it will be seated or positioned only in its position. You can, if something goes wrong, you have to maybe over widen a bit the abutments hole. So this is for the maxilla, and then you remove and you screwed in the denture. This is the physical shapes of the guides, and these guides were 3D printed, and this denture was milled out of PMMA. And then you're gonna do the same for the lower. For the lower, again, bone reduction guide, you do your reduction, then you place your drilling guide, you place your 6 implants, then you will place again the same spacer with, but this time I conceived something that I called a passive index, which is a ball and not a regular shape with straight angles, and this will actually tolerate some errors because it will act like a pivot. It will be a stopper, but it will act. It will tolerate these margin of errors because I was sure that when I'm reducing my vertical dimension by 3 centimeters, I was aware that there will be some discrepancies, that maybe the condyle is not 100% aligned with my with the patient condyle, and maybe there will be some asymmetries between the left and the right condyle while closing the patient mouth. So I conceived this part, and it helped a lot in this during surgery. And again, denture. And the idea will be that once the upper is in mouth, and you have done the surgery, and you have placed your abutments for pickup, you will have to place this denture against the upper, the lower denture against, in occlusion against the upper denture, and ask the patient during surgery to close this his mouth. And once the patient has closed the mouth, you start to assemble for the abutment pickup. So the procedure was done in one surgery. The video is 4 minutes, but I can assure you that the surgery took a bit longer.
Are we supposed to see a video?
Yeah, now it's working.
Okay.
Okay, this is the video. Now. So this was a single session makeover. You can see the result. This was like maybe the pictures were taken 1 week, maybe later. These are, as I said, temporaries. And this is how the patient looks right now. No, it's not right now. Looked when she had her temporalities. Now I don't know if we have time, or it's up to you. Either I stop my presentation here, or we can discuss and do self-critics, or I can show you how I convert this case into only 2 sessions into a final prosthesis. So it's up to you. I don't know if we have time.
Yes, we have a little bit time. Can you make this final prosthesis? Let me say in 5, 6, 7 minutes.
Yes,
and then we go into discussion, because I think a lot of people have questions to this approach.
I will skip this. Okay, so after 6 months, like after the Corona lockdown, let's say maybe 3 months ago, we have started the prosthetic part, and in the first session, you can see these spaces, voids, which were expected actually after the osteotomy. You can see that she's not very diligent with the oral hygiene. I stress on the fact that she has to clean it with water floss every day, at least 2 times, but she is neglecting it. So I consider it actually as the denture as an impression, and I relined this denture with soft relining material like this one, in this case the MG, and so this in this way I took the impression of the soft tissue, and then these are the denture which were screwed out from the patient mouth, and then screwed in the analogs. And also in the same session, while the patient is in the office, you mix some plaster and you insert the intaglio with the analogs in place into the plaster, and once it's set, you will have something like that. And then you will remove the dentures, and you will have the jaws of the patient or the master models, and you can place your scan post in order to scan it. You can also place the upper and the lower in occlusion like that, and then you will have these 2 case scenario: the models with the analogs, and the models with the dentures. The same. So you have to scan them twice. First of all, you put on the dentures, and you consider them like a wax-up scan, and you scan the upper and the lower denture as a wax-up scan, and then you remove it, and you scan your with an intraoral scan in the clinic your scan post. And before doing this, you place these 2 models in occlusion, and you scan the occlusion, and you'll get something like that. And then after having obtained all these scans, I don't know about other scanners, but this scanner will deduct or will deduce the intermaxillary position from here. So now you have an accurate intermaxillary relation. I went to ExoCAD, and I designed a Toronto bridge, or it's more known in ExoCAD like Trimble Crown Bridge. It has a lot of advantages for those who don't know. I can show you the first advantage. This was done by, the study was done by Ligevicius in 2008. He was not that famous by that time, but the study is very interesting. he assessed the following. He noticed that within a period of 3 years and a half, when the implant supported only a single crown, the risk of fracture of porcelain fracture was 1.3. When it was about bridges over implant, the risk of fracture of porcelain chipping was around 7. And when it was about cross-arch prosthesis, PFM cross-arch prosthesis over implants, the porcelain fracture risk was like 40%, which is a big amount. And I think I have the same findings, I think, in my experience. So this is why I try, by doing that, I'm minimizing my my porcelain chipping, and I consider that I'm actually converting this full arch ceramic prosthesis from full arch into single crowns by doing that. And that way, I'm considering that I'm lowering my risk of fracture into 1.3% of the crowns. Other advantages also are ease of retrievability of different components. That means, but if in case you have one fracture, you will remove only this, the concerned teeth, and repair it or redo it again, and you don't have to unscrew the whole prosthesis. Also, you have the advantage of hiding your screws in case you have in an anterior region, let's say a screw which is emerging from here, from buccal side, you will be able to just hide it under the crown. And you have also, this is also a very interesting fact, that you will have an improved method framework fit because when the dental technician is firing these crowns, he doesn't bring this big framework into the furnace again. So he is avoiding repeated firing, and he is avoiding distortions. So these are mainly the main advantages of such a prosthesis. And before I manufactured the final prosthesis, I was very concerned about my scanning and my scanning software and the printing, if they will fit. So I designed 2 bars in order before manufacturing the prosthesis in order to check the fit, and I was amazed how passive it was. Honestly, it was the first time that a framework can be that fit, that passively fit in my experience. So having that done, I proceeded with the manufacturing of the prosthesis, and you can go either full digital, that means that you 3D print or mill the substructure and the full contour crowns from zirconia, let's say, and you deliver it in one stage. So you mill everything, or you 3D print and you deliver it. I didn't, in my case, I didn't do this approach because I was limited with my dental technician, because my dental technician, who is an average guy, he's not into digital dentistry, and since he was the one who referred the patient for me, I was obliged to work at least a small part with him. So I conferred the layering of the prosthesis to him. So we 3D printed from my design here. We 3D printed the substructures, and then since it will be a manual layering technique, we have to mount it on an articulator, and also when doing the impressions, as I told you, when placing the denture and placing the analogs and so on, I also, at the stage of planning, I did this. It was retrieved, the occlusal plane was retrieved from my planning, and I did this step, the table, the occlusal table. Then I placed the upper maxilla, and then we mounted the articulator, and I even 3D printed for him some crowns so he can follow the profile of the crowns, and also to double check the occlusion. And this is the ceramics, and this is the work done. And then we have the delivery of the substructures, and as I told you here, I was obliged to do a facial, a contouring and over contouring of the upper jaw in the anterior zone in order to push away a bit the upper lip. And here around the implants, all the surface has to be flat or convex. So this is the final result. And this was baseline, and this is now how she is. So baseline after the first session and at the fourth session. To be honest with you, it took me a fifth session because I did some adjustments here in the anterior region. So basically, if we do it in a full digital protocol, I think you can be able to do it in fourth session. And I don't know why I have even more improved here, a double chin between here and here. However, the occlusion was the same in the vertical dimension. And you can see here that here without the over contour, we had like a retracted lip a little bit. And here we have a more decent and more pleasant aesthetic of the upper lip because of this over contour or the flange of the prosthesis. And that's it. Thank you for your attention. I have a part about to self-critics if you want, and to show you how things had improved. But I think we don't have time, and let's get some questions.
Yeah, thank you very much, Daniel, for this case, which is really, yeah, challenging, I will say. Yeah, it's also showing to the end with the prosto, and also the problem that still now we have to veneer these structures by hand to have a good aesthetic ceramic veneering, and then you have to go back to analog and not to full digital. So a lot of questions because of this long journey of this case, even it's done only in 4 sessions. And thank you also that you be so honest and tell the truth that you have take 5 appointments because of some correction in aesthetics, Daniel. But this is our education in the MOI, that we talk about the truth, what happens in the cases and what is working and what not working. And I'm very proud that all my students follow this recommendation. So any questions, Catherine, in the
yes,
chat?
actually, we got a question from YouTube.
Oh,
from
good.
one of the participants streaming on YouTube. It's Sven Nalder, and he is asking, what software are you using for complex surgical planning, and how happy are you with it?
In every case, I try to manipulate or to learn new softwares, but in this case, I used for the facial scan, it was the Bellus 3D. For the jaw scans, it was the Medit. For the planning of the surgery, it was Blue Sky Plan with a lot of mesh mixer and Exocard. That's
okay. Thank you, Daniel. Next question comes from Dr. Jawad. You got the microphone?
Yes, very exciting. And you have a brave heart, Daniel.
Thank you.
I wanted to ask about the reduction. For me, it seems so huge, the big reduction in lower arch. Do you think it was so necessary to do like this?
Yes. Let me go back to the planning. Can you see my screen or no?
No, you have to share again.
Yes.
Okay. So if we, because she has a class skeletal class 2 retrognathus in the mandible. So if I don't cut enough bone, I will have like a step here. You understand what I mean? I will do I will plan my denture here, and then I will have a step like that to go and follow the profile of the mandible. So that's why I removed more bone in order to give this smooth transition between the denture and the profile of the mandible. Otherwise, it will be like a step. I don't know if you got my point.
Okay, next question.
Jawad, you happy?
Yes, yes. I another question. Do you have in this system, root system, do you have angulated multi-units?
No, this type of implants, it comes like that. It has only a straight multi-unit, but it can tolerate or correct the axes up to 60 degrees. So if you have two implants, or you have like we are doing four, a node on 4 with two implants, straight implants, and two implants, divergent implants who are like up to 60-degree divergent, you will still be able to place a screw retainer in a prosthesis.
Okay, thank you.
Okay.
Thank you.
Yeah, we have more questions, actually. Next question is from Dr. Yunus.
Hi, Daniel.
Hi, Yunus.
Hi. It's a really very nice work, very nice outflow, and amazing results. Actually, I don't have a question. I have criticism and my opinion. Can I say it?
Yes, yes, go ahead.
Yeah. I have seen a lot of cases like that, and a lot of cases they were referred to me. And I have to tell you, these patients are really happy with the outcome for the coming few years only. And with this type of prosthesis and this type of implant systems, I noticed that they have a lot of bone loss later in 2 years and 3 years follow-up. A lot of peri-implantitis, infections, which you cannot treat, and mobility, explantations because of the food accumulation, which they cannot clean. I'm sorry to tell you, it's horrible.
Yeah, but usually this is I'm not inventing anything new. You have like a cross-arch screw retained prosthesis over multi-units. I don't know why it's not cleansable. I have a lot of patients like that, and a lot of literature is talking about these cross-arch prostheses, which are screw retained over multi-unit. I didn't invent anything here, and I think that these profiles and the intaglios are really cleansable. And here I believe I even trimmed a bit before placing the prosthesis to render it more cleansable. And so I don't know, I have a lot of designs, especially these designs. I do screw retain cross-arch prosthesis a lot, and I don't know.
I think because of the reduction, you reduce the actually the cortical bone, and you have only spongiosa, and then the bone is more sensitive, and you have more bone results.
Might be.
Because I have seen a lot of cases which I couldn't treat. We had to remove all the implants, and because of the implant system, I guess if you would use normal implants, which would be better for the future. I don't know for how long you are using this system, but you will see these problems after 3 to 5 years.
Yeah. Okay. So I will make a new presentation about how I manage this case.
Yeah, it would be interesting.
Yeah, good. Very nice that you discuss again this controversially. I have a question to Jonas. You have these cases especially to this root implant, or do you see only some implants which are not so famous? But Daniel introduced this kind of concept called root implant. I think it's coming from Switzerland. And do we have these cases on this implant, or you see it more or less on all implants because you have, with the bone reduction, removed the cortical plates?
I have seen it with root as well. Also, you have to dig where this implant's coming from. I cannot tell you.
Okay, good.
But because there is also, sorry to interrupt you, there is also the Blue Sky Bio is doing the same design, like a thin implant with a multi-unit on the top. And there is also an Italian brand, which is called Oxy Implant. They have also the same micro design, like a solid implant with multi-unit abutment. So
Yeah,
I don't know about them, yeah.
Yeah, because you know I work in Israel. In Israel,
Yeah.
they use a lot this system and this route. And I have to tell you, a lot of implants which they are you see on them made in Switzerland or made in Germany, and they are produced somewhere else.
No, they are not.
I know that.
Yeah.
Okay,
Yeah, of course.
okay. Good. Yeah, this is very interesting. We have to discuss later on. But I have also a question. If you have this final occlusion, we have now looking, because you use Exocad as a software, and we have 3 weeks ago, we have a device from France called Mocho. It's registering the lower jaw movements very easily, very fast, and you get a great improvement to have these full arch restorations in a vertical articulator. So my question is, you use a vertical articulator for assessing the planes and the occlusal plane and so on, but do you also make some dynamic occlusion or something more than with this articulator, or it's only static?
No, it was only static, but there is a way that I found out after the after doing this case that you can calculate somehow the Bennett angle and the condylin slope by calculating the movements of her previous dentition. I will try to show you or to send you a link about that. But yes, I'm aware about this Mojo. It costs 25,000 euros. You have also a cheaper alternative, which is Russian. It's called ProSystem. And it does the same work. I don't have any experience with it, but I think yes, this is a good addition, especially for such cases.
Okay, so we have more questions, Catherine, from the chat and from YouTube. Okay.
Yes. The next question is from David O'Dowling. David.
Hi, Daniel. Very interesting case. I was just wondering, did you have any occlusal shots of the maxillary prosthesis? Because I always struggle in changing the vertical dimension, but also I'm going to say the skeletal relationship in cases like that with the position of the anterior maxillary implants. You know, I find it a bit of reducing the tongue space for the patient, and I was just wondering how you felt that, you know.
Yeah, concerning the tongue space, I presented a lot this case in several congresses, and I had a lot of remarks regarding this tongue space. But I can assure you that she never reported me such a problem, and I don't even dare to ask her because they will start saying, yeah. Yeah. You had another question also?
No, that was me. Oh, sorry.
David, you have another question? No, please go on.
No, that's fine.
Anyway, yeah, we have to hurry up because time is running, and so we have a lot of questions. So also the other want to
next question in the chat is from Michael Basidi. Michael?
Yeah, hello. Just a couple of questions, or quick questions. First one is regarding I'll try to compress them. It's the tuberosity implants. Do you have to reflect the flap behind the tuberosity just to make sure you're not invading into the infratemporal fossa or the circummaxillary fissure?
Okay.
That's one thing. The other thing, did the patient ever consider orthognathic surgery instead of that amount of bone removal? Like it's almost like a lift forward one. You can adjust it and then start implants in an easier way. That would be my rationale from orthodontic perspective as well.
Okay, I think that we'll start with this last question. I think that with the state of her dentition, I don't think that it was an option to tell her, you know, go.
Not also like orthodontic surgery, just to adjust
but
the skeletal relation,
yes,
and then you
but
can
you
do
have
your implants.
Yeah, but you have to do a pre-treatment before, an orthodontic pre-treatment before, to adjust everything, and then I think I don't know. My wife is an orthodontist, and she said that that you have to do an orthodontic.
And usually with the mandible, because with these cases with VMA or vertical maxillary excess, if you intrude the molars, which you did through your osteotomy and your implants, there will happen mandibular translation that will move the mandible forward. You can guide it even with the prosthesis, so you don't have to remove a lot of bone from the mandible, like Eunice was talking about before. That was my only concern from a orthodontic perspective. Yeah, that's all. Thank you.
Yeah, but I have to add, okay, I have not, with all things, I'm very happy with this case because we can discuss now hours for that, because it was a very challenging. But Daniel, I think you want to show how fast it works if you go this approach. And the other approach with the orthodontic surgery and so on is, of course, taking a little bit longer time, and you have more appointments and so on. But I agree with Michael Basili, right? That we have to discuss also these other treatment options seriously. But of course, once you have to find a decision, and we know we have a lot of alternative therapies, and so as long as it works, we say nothing is wrong or right. It's another option, right? Okay. So next question, Catherine.
I just wanted to add that I have almost exactly the same case that I've done like 3 years ago, but in an analog way, okay? And it took me maybe more than 30 sessions, and during maybe one year and a half. So I was just telling you and showing you how fast is the digital dentistry and how things are evolving.
Okay, so Catherine.
Okay, yeah, then the last question is from Dr. Zuman Reddy. You have to, yes, we can hear you. Hi.
Hi. Hey, David, that was an amazing case. I did a similar case in February, but with the regular implants. I just had a question whether this is the same as the single piece implant, what we call it back home here in India.
I know about these implants they are talking. The other implants that you are talking about are one-piece implant that have an abutment on their top, right? No, this is not the same. This is the same, I think, the same company that is manufacturing, but this is another thing. This implant has a multi-unit on the top, not an abutment.
Correct. We are getting certain single piece implants with multi-units. As you said, they're fixed and you can manipulate the axis however you need.
No, if you are asking if it's bendable, no, it's not. If this implant is bendable, it's not.
Okay, it was an excellent case. Thank you so much for the presentation.
Thank you.
Okay, I have a last question. We invited a lecturer recently, and he is also working on a software where you can calculate the change in the face after you change the vertical dimension or you make some orthokinetic surgery. It's AUP do you use also this kind of software, because you work with three-dimensional faces and so on, and you show, okay, this is the profile before and after the treatment, and even after the final one, it's changing again. But this is our photo which you make after you inserted the temporary or the final restoration. But do you know also, because you're really deep in this kind of digital workflow, that we can use perhaps in future also the pre-calculation of the changes in the face and the profile ahead of surgery and ahead of bone reduction, because this will be very helpful to rule out some really bad outcomes.
I have only heard about these softwares. One of the softwares is called, I'm not sure about it, is Dolphin. All the orthodontists are using it, and I have heard that a long time ago they were being able to simulate the skin and the facial aesthetics after orthodontic surgery. I never seen this software, but I've heard that it can do such things. And we all have also now in the US, I don't remember anymore the name. They are these facial scans that I showed are static, but in the near future they will be dynamic.
Yeah, because this approach is coming for the orthodontists and for the orthokinetic surgery, right?
Exactly. Yeah.
And so this is this field, but we come from the implantology, and if you make a bone reduction in this amount, like your case, you are more or less similar with orthokinetic surgery in the dimension, right? So if you make a LIV4 surgery, what we already hear, you have in the final also this kind of reduction. And so I think for the future, it will be nice to integrate not only the chewing of the with Mocho others, also to integrate software which give you some more predictability of the changes in the whole face with this kind of bone reduction. And because it's what you say, with the virtual patient, we get more and more added software, which we can do a lot of calculation ahead of we doing it. And appreciate if you go on this way as a MOI alumni and and push it forward. Even we have always in the end a discussion if this is really the right way to make this kind of case. Especially for the hygiene, you see, after you get it back 6 months later, this woman has no idea of hygiene, right?
Yeah. Okay.
Good. So, Catherine, I think it was my comment was the last one.
Yes. There's no more questions. The goodbye message will be yours, Paul.
Yeah. Okay. Everything has a start and an end, and unfortunately, we are now in the end of this kind of online congress, and we have to thank you that you all stay here, and we have it recorded. You can also see it in YouTube, and I have to thank first my staffs. Yeah, you see, everything is working very stable. With all these preparations ahead, and I'm very proud to have this behind me. This is a team approach, you know. It's exactly the same like if you do it in your office with all of these nurses and dental technicians and whatever. On the other hand, I have to say thank you to every lecturer taking a lot of time and effort to prepare this lecture and to do this lecture. Some of these lecturers you hear have 400 already or 500. Some of the lecturers have only 1 or 2, but all of these lectures were very, very nice and on a very high level in the presentation and also in the content. So I'm very proud on this kind of congress again. Therefore, we are absolutely sure that we have again this kind of MOI annual congress, and hope God that we have it now again in Frankfurt personally, because all these social things are a little bit missing, coffee drinking, beer drinking, party and so on. But I think in next year we will have it again. It was September 9 to 11, so it's a very nice wording, 9/11/2021. And so it's a 3-day event, and we do everything to have again this kind in Villa Kennedy of this event of this MOI annual congress with the graduation ceremony in the next day. You can contact us again over the website or directly over the email if you have any questions also to these lectures. We will forward it to the lecturers and we'll support you. And of course, we are needing you that you recommend us our program to survive, because it's now a very hard time, and if students come again, we will be very happy. And so till now, we are very, very nice working together with you. And I will say goodbye and keep healthy. And we will very happy if you talk about this Congress and about the quality of this Congress to your friends and to the implant community and to the dental community, so that we have again more and more interested to join our program and that the family is growing and growing and growing. Yeah, this is my personal wish. And thank you, keep healthy and have a nice weekend. Bye-bye.
Thank you, Sean.
Bye.
Bye, everybody.
Bye, everybody. Thank you.
Ich schalte aus, ja?
Okay.